Seriously?
I'm alone.
You've been caucusing with yourself, have you?
No.
Now try.
Testing, 1, 2, 3.
All right, good morning, everyone. Welcome to the Health Coverage Insurance and Financial Services Committee. This morning, we have a public hearing and a couple of presentations. Later this afternoon, we'll have work sessions. Before we get started, I will ask committee members to introduce themselves, starting with Representative Chimino, if you're ready.
Good morning, everybody. Thank you for being here. I'm Representative Mary Grace Chimino. I represent House District 83, which comprises the towns of Bridgeton, Harrison, and Denmark.
Good morning, everybody, and thank you for being here. I'm Representative Poppy Arford. I come from State House District 101, the western part of Brunswick.
Good morning, Representative Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good morning. I'm Sally Clucci. I represent House District 52, which includes the communities of Bowdoin, Bowdenham, and Richmond.
Good morning. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springvale.
Good morning. I'm Representative Josh Morris. I represent House District 91, which is Turner, Leeds, and Lee.
Good morning, everyone. Welcome. Representative Paul Flynn, House District 63, towns of Winslow, Albion, Freedom, and Unity Plantation. Thank you.
Good morning. I'm Rolf Olson, District 86, which is Raymond, Casco, Fry Island, and a bit of Poland.
Good morning. My name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good morning. My name is Christy Matheson. I represent District 151 in Kittery, and I serve as the House co-chair.
Good morning. I am Senator Donna Bailey. I represent Senate District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair of the committee. So first order of business is a public hearing on LD 2087, an act to amend the laws governing the licensure of American Sign Language interpreters, presented by Representative Matheson.
Good morning, Senator Bailey and honorable members of the Committee on Health Coverage Insurance and Financial Services. I am Representative Christy Matheson. I represent House District 151, the lovely seaside community of Kittery. I'm here to present LD 2087, an act to amend the laws governing the licensure of American Sign Language interpreters. This is a Department of Professional Financial Regulation bill that implements key recommendations from the Transforming Interpreting Main Time Needs Assessment Report issued by the Department of Health and Human Services in 2024, following the October 2023 Lewiston shooting. The bill authorizes an emergency exemption to American Sign Language interpreter licensure during declared emergencies. It creates a broader educational pathway to licensure and extends conditional licensure from 4 to 5 years with the option of a 6th year in cases of extreme hardship. The department is here today, and I respectfully ask that you direct most of your questions to their representatives, and I thank you for your time and consideration.
Thank you. Questions from committee members? Seeing none.
Thank you.
Thank you very much. And we do have a representative from the department on Zoom. I think we'll just take her a little out of order so she can testify first. Good morning.
Good morning. Senator Bailey, Representative Matheson, and members of the committee. My name is Penny Valancourt, and I'm the director of OPOR, which has oversight over 38 licensing boards and programs, one of which is a program, the American Sign Language Program, that is subject to this legislation. And again, thank you for the opportunity to testify remotely and taking me out of order. LD 2087 is a work product. And again, important for me to share, as was stated by Representative Matheson, that this came out of a work group, a committee that was convened in the wake of the October 2023 Lewiston shooting, in which DHHS led an initiative to understand American Sign Language interpreting services in Maine. LD 2087 reflects recommendations from the initiative's report, referred to earlier as the Time Report, which seeks to address ASL interpreter workforce shortages. The recommended changes are to add an additional educational pathway to licensure, extend the conditional licensure period, and expand the exemptions to licensure as noted during emergency situations. More specifically, LD 2087 proposes to amend the educational qualifications for licensure to include degrees earned in fields other than American Sign Language or deaf interpreters. It is not anticipated that this will in any way diminish the minimum standards required for licensure, as a conditional licensee applicants must still pass a knowledge exam and document proof of a qualifying score on an ASL proficiency interview. This proposed change also aligns with the Registry of Interpreters for the Deaf, which is known as RID, and their certification requirements, which is still a certification needed for full Maine licensure as a certified interpreter or a certified deaf interpreter. Also, that candidates pursuing the National Interpreter Certification or Certified Deaf Interpreter Certification must have a minimum of a bachelor's degree in any major prior to taking the generalist performance examination. As noted earlier, this is a technical change in such that it extends the conditional licensing period from 5 to 6 years This change is also intended to give applicants more time to pass the RID performance examination, which is again required for certification, and for applicants to earn a bachelor's degree, a prerequisite for performance exam eligibility. And again, as noted earlier, this bill also adds exemption language to clarify exemptions to licensure when there are emergencies as determined by the director of OPOR in consultation with the commissioner, such that a serious, unexpected, and potentially dangerous situation requires an immediate need for interpreting services to be provided as part of an emergency response. This change in the law will allow the department to be more flexible and responsive to meet the demands for interpreting services in times of crises. Thank you for the opportunity to share our support for this bill, and I'm happy to answer any questions now or at work session.
Okay, thank you. Questions from committee members? Representative Foley.
Thank you, Madam Chair, and thank you, Annie, for being here. Was the Maine Association of the Deaf, were they part of the working group?
That's a great question. I'm not sure that I can answer that, but perhaps those testifying behind me can. And I believe there may be folks from the Department of Labor and or the Department of Health and Human Services who might be able to answer that question. If not, I will get that answer.
Have you seen their letter that they sent with some possible amendments?
And that would, no, I have not seen the possible amendments submitted by the association. What I can share with you is I did have a conversation with a steering committee on Monday that anticipated their request to allow students, I believe, the opportunity to obtain licensure while completing their degree program, similar to, I believe, more of an apprenticeship type structure. So that's as much as I'm familiar with any proposed amendments. So happy to review what they've submitted and get back to the committee on that.
Thank you.
You're welcome.
Further questions? Seeing none, thank you for joining us. Are there other people in the room wishing to testify in favor of this bill?
Good morning. Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage, Insurance and Financial Services. My name is Betsy Hopkins, and I am the Director of the Office of Aging and Disability Services within the Maine Department of Health and Human Services. I'm here today to testify in support of LD 2087, an act to amend the laws governing the licensure of American Sign Language interpreters. You've already heard the goals of LD 2087. I'll just review briefly. To extend the maximum duration of conditional licensure interpreters for interpreters from 4 years to 5 years with possibility of a 6th year. Broaden the educational pathway to licensure by allowing an associate degree or higher in any field, including but not limited to ASL interpreting or deaf studies. And establish an emergency provision clarifying that interpreter licensure requirements do not apply to a person providing communication assistance during an emergency response, as determined, as already explained, by the director after consultation with the Commissioner of Professional and Financial Regulation. The department does not anticipate a fiscal impact to this bill. The Department of Health and Human Services, through Office of Aging and Disability Services, supports this Department of Professional and Financial Regulation bill. These past 2 years, OADS has worked closely with the Maine Division for the Deaf, Hard of Hearing, and Late Deafened, the Department of Labor, the Department of Professional and Financial Regulation, the Department of Education, and other partner agencies to promote communication access for deaf, deafblind, and hard of hearing individuals so they can fully participate in healthcare, education, employment, legal proceedings, and community life. Reliable access to qualified interpreters is essential to safety, independence, and equitable access to services, particularly in rural areas where workforce shortages are most acute. The challenges addressed by LD 2087 were, as we described, underscored during and after the October 2023 Lewiston shooting. Through the Transforming Interpreting Maine project, deaf and hard of hearing community members described significant gaps in community access during emergencies, as well as longstanding shortages in the ASL interpreter workforce. Extending the conditional licensure period provides additional time for interpreters to complete required credentials without unnecessarily leaving the workforce, while maintaining appropriate licensure oversight. Expanding the degree pathway removes an artificial barrier to entry that can limit the pipeline of qualified interpreters, particularly for Mainers whose educational backgrounds fall outside narrowly defined programs. Finally, the emergency exemption provides clarity during emergency response situations so that communication assistance can be mobilized quickly and in coordination with state leadership when time-sensitive, potentially dangerous events occur. For these reasons, ODES urges the committee to support LD 2087. The bill reflects community-informed recommendations, strengthens Maine's ability to respond during emergencies, and supports a more sustainable interpreter workforce while maintaining appropriate oversight. Thank you for your time, and I'm available to answer questions or be available during the work session.
All right, thank you. Questions from committee members? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify in favor of this bill?
Good morning, Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Libby Stone Sterling, and I'm the Director of the Bureau of Rehabilitation Services in the Maine Department of Labor. I am here to testify in support of LD 2087, an act to amend the laws governing the licensure of American Sign Language interpreters. The Bureau of Rehabilitation Services in the Maine Department of Labor works to provide full access to employment, independence, and community integration for people with disabilities. Through the Bureau's Division for the Deaf, Hard of Hearing, and Late Deafened, and its vocational rehabilitation programs, nearly 1,200 deaf and hard of hearing job seekers are supported each year on a path to meaningful employment. For many of these individuals, access to ASL interpreter services is a prerequisite to participation in education, training, and employment support services. The terrible events in Lewiston in October 2023 raised awareness of the critical importance of language access in an emergency, and more broadly shined a spotlight on the lack of access to American Sign Language interpreters across Maine. In response, the Department of Health and Human Services, as you've heard, in conjunction with the Departments of Professional and Financial Regulation, Education, and Labor, commissioned the comprehensive Transforming Interpreting Maine Time Report, which was released in June 2025. The report was developed with significant input from the deaf community, ASL interpreters, and other important stakeholders, and through its recommendations, identified opportunities for Maine to strengthen access to ASL interpreters. Barriers identified in the Time Report included that current degree requirements create unnecessary barriers for qualified interpreters while not directly correlating to interpreting competency. In addition to the critical changes proposed in this bill related to ASL interpreter licensure during an emergency, LD 2087 proposes changes that would broaden the educational pathway to licensure and in doing so expand the pool of potential ASL interpreter candidates. The Maine Department of Labor recognizes the importance of expanded career pathways and is working closely with its Maine Apprenticeship Program to explore opportunities to establish a registered apprenticeship program for ASL interpreters. These efforts will complement the licensing changes in this bill. Thank you for consideration of this information. I am both available to answer questions and to attend the work session if that will be helpful.
Thank you. Representative Matheson. Thank you.
Thank you for your testimony.
Okay.
Could you just go into a little more detail about this apprenticeship program and where it's at and what the funding is and how are you reaching participants?
Sure. So we really are still a bit in the early days. We've been collecting information from across the country. There is only one other that we've been able to identify registered apprenticeship program that's been established, and that's in the state of Wisconsin, and for ASL interpreters. And so we're working very closely to gather that information. They've been very generous and have shared all of the pieces that they've put together. We met with them right before the New Year's holiday, and we're able to get those pieces of information. We have regular meetings where we're reviewing that. We're also looking at what other New England states are doing. And I believe in terms of our apprenticeship program, we're looking at the money that we're currently spending now on interpreters. We're understanding where there may be some additional resources through grants and other resources for the apprenticeship program, which, as you know, is very popular right now. And we're working very closely with the steering committee that was referenced earlier to make sure that we have all the pieces in place as we're moving forward. We're hoping to start with kind of a pilot apprenticeship and then to move out depending on the success of that effort. Thank you.
Further questions? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify in favor of this bill?
Good morning to all of the committee members, Senator Bailey, Representative Matheson. I'm happy to be here this morning. My name is Matt Webster. I am the director of the Maine Association of the Deaf, and I want to make sure that the sound is good and the visuals are good.
Yes.
I'd like to say that MEAD, or the Maine Association of the Deaf, recognizes that LD 2087 is an important beginning. We support the emergency exemption provision, the extended conditional licensure period, and especially the broadened educational pathway in Section 2 that allows degrees in any field rather than only ASL-specific degrees. However, we cannot fully endorse this bill without two critical amendments. But we do want to recognize that the flexibility in allowing for these other degrees is tremendously important into taking down some of the barriers people face now in entering the field. So an AA degree, so students who are in the interpreting program for a full BA, they now are locked out. So a junior and senior who is going through a BA program at USM, which is a nationally accredited interpreting program, would not be able to work without graduating with a BA. And this presents a barrier for those students. So one of the amendments that we are recommending is that we allow conditional licensure for students who have completed at least 60 credits towards a bachelor degree in any field and are in good standing. This builds on LD 2087's any field philosophy. The other gap that we feel exists in the current iteration of this bill is that alternative pathways are blocked. And we feel that the current law limits RIDs, or the Registry of Interpreters for the Deaf's alternative pathway, and it limits it to grandfathered limited license holders from 2021. The current bill, LD 2087, does not address this or fix this. So the alternative pathways, we feel, would do much to allow the removal of many of these barriers. We propose amending subsection 2 to remove the grandfathering limitation and to make RAD's alternate pathways available to all conditional licensure applicants, not just those who held limited licensure before 2021. Alternative pathways, it can mean that we're recognizing people's life experiences, their work that they have done through coursework, their experience that they might have had actually interpreting pre-licensure and pre-certification. This also would be of benefit to us in supporting an apprenticeship model that works quite well, as we've seen with other apprenticeship programs for individuals who are not well suited to a college formal education, but do quite well with that more hands-on approach. The Maine Association of the Deaf urges the committee to amend LD 2087 to add the 60 credit pathway for students, which addresses what I'm calling gap number 1, and to open the Registry of Interpreters for the Deaf's alternative pathway for all applicants, which addresses what I'm calling gap number 2. And without these amendments, Maine continues to restrict the very pathways that would build our interpreter workforce. The deaf community deserves qualified, experienced interpreters, and these amendments, while maintaining all quality standards, remove unnecessary barriers that prevent students and experienced interpreters from gaining supervised practice. I thank you, and our full written testimony, including specific statutory language and references, is submitted for the record. Questions?
All right, thank you. Questions from committee members? So I do have a question on the proposed amendment allowing students. And I'm familiar, just you don't know this, but I'm an attorney and I'm familiar with, for example, at the law school, they do allow students to practice law through the clinic under supervision. So are you envisioning for these students like any supervision requirement?
Yes. Yes, thank you for that question. That would be the goal. USM now has a practicum program that is provided to students, but it's typically just 1 semester. So this would open it up to a 2-year practicum-like experience that allows people to be apprentices and to be involved in practicum with supervision while they're at USM.
Thank you. Any further questions? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify in favor of this bill? Anyone wishing to testify in opposition to this bill? Anyone wishing to testify neither for nor against this bill? Right, any requests from committee members for the work session? Seeing none, hopefully you can have some discussions with Ms. Valencourt about your proposed amendments and see if you can reach some agreement. But we would anticipate this would come up for work session next Wednesday, right? Thank you.
Just wanted to make sure you let them know that.
Yeah.
Thanks.
All right. I will close the public hearing on LD 2087. And we next have scheduled a presentation of the GEA report on the State Employee Health Commission. Hopefully, yeah, because we're right on time. Yeah, right.
I am not.
Oh, okay.
Yes.
We're right on time. It's unusual in the last.
I'll be here shortly.
Okay, great. Thank you. Appreciate it. I just sent an email.
Yes, that's what.
Respond back to your area. Great.
Welcome.
Thank you. What's that? You don't have to. You don't have to. This is from then. I think we're good. Yeah. What's the other chair?
Maybe it makes sense. I guess. Yeah, regulated in my own world. Right. They do that at the last. Right. They know the student. Right. Under supervision. No.
Yes, you go.
Yeah. Experience, obviously. Right. Experience, et cetera. So, yeah, it makes sense to me.
Okay, all for her? Right. Thank you.
No.
Sit, ma'am. Ma'am, is there two? You just did the
Intro.
Thank you.
Refresh our memories, huh?
Yeah, exactly. It's been a while.
Yes, it has.
Thank you.
We're good. Yes. All right, great. So I just wanted to refresh everybody's memory a little bit. We talked last session about the committee's responsibilities under the State Government Evaluation Act, but the blue sheet is just a highlight of the process and the statute that requires a periodic review of agency boards and commissions that legislative committees have jurisdiction over. And pursuant to the Government Evaluation Act, the act requires, as I mentioned, for a regular periodic review of the performance of these agencies that receive general fund money or that are established by statute. It's a pursuant to the law, it's a periodic review that happens every 8 years. So the State Employee Health Commission was previously reviewed by I think it was the Insurance and Financial Services Committee back then, but 8 years ago. And so they're back again pursuant to statute for the committee to have the opportunity to review them. The statute basically lays out sort of 4 core kind of components of the review. The agency is required to complete what's called a program evaluation report, and that's what you'll have presented from the commission today. And then following that, the committee will schedule additional meeting and work sessions to complete the review. But as you listen to the report, I think it's important to remember sort of the criteria that the lens that you're required by statute to think about as you're reviewing the agency or the commission in this case. The act lays out sort of, as I mentioned, sort of 4 areas, the extent to which the commission is operating in accordance with its statutory authority, the degree of success in meeting its goals and objectives for the program, the degree of success in meeting its statutory and administrative mandates, and the extent to which they have increased or reduced filing and paperwork burdens on the public. That's sort of a specific item, but I think really you're looking at the agency operating within the scope of its statutory authority and doing it in an efficient way. And the committee has the opportunity through its review to make recommendations to the legislature for changes. It can be through a piece of legislation. It can be through communication with the commission. Can you sort of have broad authority in that way to implement changes or set new goals or however it is that you want to communicate with the entity. So the last thing I would mention is there are some important sort of statutory guideposts and guidelines in the statute. The statute requires that the committee begin its review by February 1st. So that's why we're beginning the review today. And the statute requires that the committee submit a final report to the legislature by March 15th. And when we have our next work session, I'll provide for you some examples of what committees have done in the past as part of a GEA review. Some people remember that in the past we've reviewed licensing boards, and they've actually recommended some statutory changes that the committee has moved forward with. Other times we've reviewed agencies and the committees has made a determination that the agency or the entity is operating within their statutory authority, and the report is simply, we agree that they're operating within their authority and we make no other recommendations. Sometimes the committee has said, we agree, you're operating within your statutory authority, but we'd like to see these changes, and the committee has followed up with a letter. So we'll talk more about your options at an additional work session, but the purpose of today is to kind of begin the review with the presentation of the report. And the elements of the report are laid out in statute. And so there's some consistency that you may recognize with some of the prior reports that you've received, but understanding that this is a small entity that you're reviewing in comparison to, you know, the Department of Professional Financial Regulation, for instance. I also attached for you, which you may also see in the report, the statutory authority for the establishment of the commission is on the second page of the blue sheet. But with that, I guess I'll defer to Shauna Poulin Gutierrez, who's going to present the report on behalf of the commission. And that's on White.
Good morning, everyone. Senator Bailey, Representative Matheson, and members of the Joint Standing Committee. My name is Shauna Poulin Gutierrez, and I'm the Executive Director of the Office of Employee Health, Wellness, and Workers' Compensation. Long title. I also sit as part of the State Employee Health Commission. Today, I'll be sharing highlights that are contained in the government evaluation report, which you all have in front of you, and there has been an electronic copy provided. I'm going to try to take some highlights. I know there's about 16 pages in that report, so I'm going to jump right in. The State Employee Health Commission is composed of both labor and management members and serves as the provider of recommendations for the health, dental, and wellness plans, as well as the trustees of the group health plan. The report outlines the names of the commission members, and you'll note that we do have some vacancies. There's about 6 vacancies at the time this report was submitted, with more of those being labor seats. And the commission has 2 chairs, co-chairs, Jonathan French representing labor and Michael Dunn representing management. The commission meets on a monthly basis and annually reviews the benefit design for both our active and retiree population. The focus is to deliver high quality and affordable care, looking at our service areas and the geographic reach of our population, knowing that our population is spread out across the state and in some cases across the country. It's also been very important to stay connected to members, providers, and other organizations to positively influence healthcare and delivery systems. We are one of the largest self-insured plans in the state with about 28,000 covered lives. And we currently have Anthem as our carrier. We have nearly 25,000 members that are state of Maine employees and their dependents, from executive branch, judicial, and legislative branches, as well as what we refer to as ancillary members. Ancillary members are the community college, Maine PERS, Maine Turnpike Authority, Maine Maritime, and several smaller groups. Also included on our active plan are what we refer to as our non-Medicare retirees. Those are individuals that have retired but are under the age of 65. And we have 1,527 of those members at the time of this report. And if you're kind of following along now, I'm sort of on page 6 of the highlights. The state of Maine Also has a self-insured group dental plan with Northeast Delta Dental. The plan has 12,303 employees and 10,766 dependents. The plan offers 3 tiers of coverage with non-participating dentists. So there'd be more out-of-pocket cost share for those using that group. Then we have the Northeast Delta Dental participating tier, and then the preferred provider group, which would have the least amount of out-of-pocket expenses for those using that tier. Also worth noting in the report, when asked about the financial summary for the last 10 years, the commission does not have a budget allocation or a direct funding source. Expenses incurred by the commission members for travel to attend meetings are reimbursed, and this is outlined by statute and collective bargaining agreements. It should also be noted that these costs are often very minimal, given that our meetings are using a hybrid approach now, and many people attend virtually. Expense reimbursement is provided through the State Employee Health Insurance Program's administrative budget. The Accident, Sickness, and Health Insurance Internal Service Fund provides funding sources for the administration of the health plan and related services. And you will see in the report noted that we have an administrative fee that's assessed to the agencies. Another piece that's notable in the report and timely, last year, this committee asked the question.
Can you just direct us where you are?
Oh, sure.
Can you just
Yes,
direct
I'm
us
on
where you
page
are?
8.
Thank you.
Yes. I have the Cliff Notes over here.
Thank you.
So page 8, so last year, this group did ask us to take a look at the eligibility guidelines. So there was some intensive work looked at for those that could participate in the group health plan. So we did develop some guidance that the committee could consider before making policy recommendations, before adding ancillary groups in the future. We don't anticipate that our membership will fluctuate that much in the future based on the recommendations. A couple notable things from the recommendations was looking at the current ancillary groups and considering that a lot of these groups are quasi-government entities. Also looking at the interest of the parties and if they have funds being appropriated to them in the budget from the state as part of the criteria. And again, I mentioned earlier, those ancillary groups that can participate in our plan, in addition to some of the larger ones that I mentioned at the top of the highlights, we have 2 non-governmental groups that are eligible, and those are blind persons operating a facility under the Department of Labor. Then we have a division for the blind and visually impaired, and licensed foster parents caring for children whose care is reimbursed through the Department of Health and Human Services. So there are a couple of those smaller entities that are eligible for our group health plan. And the retiree eligibility is in alignment with those same requirements. Right? And we often say that data drives our decisions, and the contracts that we have in place helps us do so. So the contracts that we have use claims data management systems. We use actuaries for analysts, and these pieces of information within the contract help support decisions made by the commission. Also, communication. Yes.
Representative Clutch.
Thank you, Madam Chair. Just a quick question. You'd mentioned that the acronym, the long acronym. Implements and administers service delivery. I'm curious, because Aetna's serving as the third-party administrator, do they not offer that kind of service?
So Aetna, for our Medicare Advantage plan,
Sorry, not Aetna, I meant Anthem.
Oh, okay.
Sorry.
So we do all of our enrollment. So the enrollment comes directly through our office. So Anthem doesn't do that for us. We supply those files and then we pay our claims through Anthem upon review on a weekly basis. So there are many administrative pieces to the relationship for the office.
Okay. All right, and then you're talking about data and that you're working with private organizations to manage the claims database and helping provide decision-making. I'm curious if it was ever considered whether MHDO would be the
We are a partner.
you are.
Yes, they have
Okay.
our data as well.
Okay. All right. Thanks. I'll stop asking questions.
So we use, and it might come up in the report too, we have a relationship with the Healthcare Purchaser Alliance. And we use consultants, Locked In, which we go out to bid for, who also analyze our claims. And we have Capital RX for our pharmacy, and they have a claims management system as well, which is able to give us information on those higher utilizing drugs and the cost, and they give us our average monthly cost per member too for prescriptions or different disease areas as well. Okay. And just see, still on page 8, communication continues to be vital to our membership. And back the last time this report was submitted, and I think it was 2017, we did use that, what we call that direct mailing, the snail mail. We still use that today. Our membership is across the state, and we still find that to be a valuable resource. But in addition to that communication method, we have really enhanced the information that you can find on the website. We've also begun using social media, and we use email blasts with key contacts. And then one of the things that I think has been a real game changer for us is using benefit bulletins. And those are delivered through Constant Contact. And Constant Contact is a email service, and they track our clicks and our open rate. So we're able to see if people are engaging in our messages, and we aim for about 4 a month of those just really short bites of information through benefit bulletins. So moving on to page 9, another significant change since the last reporting period is the big changes in the overall healthcare trends. So in 2022, trends dipped largely as a result of the pandemic, as I'm sure we're all aware, followed by a 15% increase in 2024. This is from both higher costs of healthcare and increased utilization. It's often been noted that during the pandemic, there was a lull in utilization, and then once people were able to regain some of those regular appointments, there was a pretty significant increase in utilization. And in some cases, some individuals may have delayed important screenings too, which could generate more needed appointments. Prescription drugs tend to remain in double digits, and contributing factors for this include rising ingredient costs and increased utilization in medications like we've all heard about GLP-1s lately. Those do contribute to some of our costs. Let's see, a couple other notable pieces in the section on page 9. Between plan year 2019 and the projected 2026 plan year, the self-funded plan for active employees is expected to increase at a cumulative rate increase of 38.2%, averaging about 4.1% annually. By comparison, and with work with our consultants, they projected claim cost increase from 2025 to 2026 to show a cumulative increase of 69.5% for an annual average of 6.8%. Yes.
Representative Cloutier.
Thank you, Madam Chair. What do you think explains the difference? Why is Maine less? Or why is our plan less?
So we do a good job of managing costs because of this group. We're constantly looking at ways to utilize best-in-class services, and prevention has been a big focus of the plan as well. And I think those in healthcare would say prevention can really help avoid costs and improve health outcomes as some of our key drivers. And then there is in the report there's a few strategies that I'll talk about in a little more detail if I have time for cost savings. Yes.
Representative Arford.
Just to follow up on the previous question, in the comparison that's being done here, is the population that we're comparing with a comparable population to our state employee population?
Yes.
It is.
That's a question. That's a great question.
Yeah, thank you.
Because we are an older population in the state of Maine in general and for our plans. Great question. For several years, the commission has used the rate cap for CPI, Consumer Price Index, plus 3%, and this is indicated in statute as our limit for our premium increase. And so just to give you a couple stats from the CPI, from 2018 to 2021, this ranged between 4.4% to 5.3%. Then in 2022 to 2023, this ranged from 10% to 9.5%. Then when we look at 2024, CPI decreased to 6.4%. So in 2024, the industry-wide healthcare inflation exceeded the statutory cap, and the state's experience was even less favorable than the broader market. This mismatch led to substantial plan design changes starting in 2025, including higher member deductibles, copays, and out-of-pocket max increases. In 2026, we're seeing these trends expected to continue to increase. Just do a page back here. This is right before page 11. So in there's a quite a bit of detail.
I'm sorry, another question.
I'm sorry. Go ahead. Yes. Sorry. Thank you, Madam Chair. I don't think I totally understand the cap and the statutory cap. And then can you just maybe say it again using plainer language and then also help me understand, because it looks like from 2019 to 2026, we've done a really good job at keeping costs down. But then you say from 2018 through 2024, we're exceeding our cap. So I'm having a hard time understanding what's happening.
Yeah, so the cap is not our cost. The cap is per statute what we're allowed to increase the health insurance premiums to. And so when we look at what our actuaries are predicting to be our working rates, then the increase is bound by no more than that CPI plus 3%. So if our cost experience is higher than what we are allowed to increase the premiums, then we have to look at plan design for savings to make up that difference. So our costs were greater than what the statute allowed us to increase.
So for the work session, Colleen, I'm sure can get you that statute so you understand it. But it's in statute. So they're limited in terms of how much premiums can increase. It's currently CPI plus 3%, although there is a bill where they're seeking to increase that in another committee. But so, when they look at the plan design, they have to work within those parameters. And obviously, if the allowed increase doesn't cover what's anticipated, then they make adjustments other places, like increasing copays or deductibles or whatever, so that the math works.
Right.
I'm simplifying it, but that's what she's talking about.
Can I just recap to make sure I understand? So we've done a good job compared to sort of others, and yet our costs are still gone up and we're hitting, and so the cap, we're exceeding, our expenses are still exceeding what we're allowed to charge. Is that so? So if I'm understanding those two sort of paragraphs separately, like we've done a good job compared to like sort of you know, however, we're still in a not a great position because we've had to raise rates because costs have gone up.
Costs have gone up.
Yes.
Yeah.
Thank you.
And so that CPI plus 3% really worked back when costs were lower, but now that costs continue to increase, we are being forced to look at plan design. So, and I think if I'm needed at the work session, I'm happy to attend to answer questions in the future. Also notable in that report, in that same section, the State Employee Health Commission has looked very carefully at how we compare to other public payers like the City of Portland, the teachers program, the municipalities trust. And we've always been very comparable, a good, great, favorable plan. But in this last year, when we were forced to change our plan design, we are now not quite as favorable as some of those plans when you look at co-pays and out-of-pocket deductibles. And so, as noted by Senator Bailey, you will see in the report that the commission and the office and DAF's leadership did introduce a bill to raise the statutory cap to CPI plus 3%, up to 10%, excuse me. I'm so used to saying 3%. And this is LD 2148. And we have heard from our membership that they would rather have a smaller or more gradual increase in their premiums over time, paycheck deduction rather than a large copay changes or deductibles, with that pre-tax deduction coming out of their check for their premium being more favorable.
Representative Matheson, thank you.
Just want to clarify, you said the bill has up to 10%?
Yes.
Thank you.
Plus
Representative
CPI.
Arford.
Thank you, Madam Chair. So I'm sure it's in the report, but I'm just going to ask this now. So what we're talking about is the way that this increase of cost is being managed is by increasing, or at least looking to increase our out-of-pocket costs more significantly as we go forward. Is that correct?
Don't change our CPI plus 3, the percentage plus the CPI, then we will be forced to change our out-of-pocket max or different coverage pieces.
Okay,
with plan
so what's happening with the benefit structure of the plan? Are we making any significant changes in that? I mean, I have the plan, but I'm not a big utilizer of it, so I don't know. I do know that the out-of-pocket costs, from my perspective, did increase significantly this go round, but I don't know about what's the plan is actually offering for coverage. Is that also being changed significantly?
I suppose it depends. So we do have some changes in coverage, and there's a program that we use for centers of excellence for certain surgeries, MSK. So that is a coverage change. We are using steerage through Carum for cost savings. So individuals will need to go through Carum first before scheduling knee or hip surgery. So that is a plan change, but a lot of the like network has remained intact. Network has not changed. And procedure coverage, I guess, to get granular has not changed.
Thank you.
You're welcome.
Question. So I just had a question in terms of, again, talking about raising the cap versus, I'm just going to say raising deductibles.
Sure.
But I understand it's more than that. Have you looked at giving folks an option? So you were saying, well, most of our members are saying, no, we'd rather pay more in premiums versus higher deductibles.
Right.
But again, have you looked at having an option? Here's the option, you can pay more in premium with lower deductibles versus here's another option where you would have higher deductibles, but your premiums would be lower.
Yes, that's a great question. So that would mean, if I'm understanding your question correctly, having more than one plan.
Yes.
And that is something that we've looked at. There was a request by this committee, I think a couple years ago, to evaluate a high cost plan. So there's a report that was submitted. At the time, there was also noted complications because administratively, we didn't have the key functions to be able to offer more than one plan. We do have a new HRMS system now, just launched in September. But that report is something that I could easily pull up and share with the
Yeah, I'm
committee.
sure Colleen could get it for the work session too, so we might consider updating that report with the kind of the changed circumstances.
Mhm.
So, thank you.
Yep. Welcome.
Representative Matheson.
Thank you.
Also, have you looked at other carriers other
Yes.
than Blue Cross Blue Shield?
Yes, that's very important. So we do continue to go out to market and look to see where we can get the best rates. So while we have had Anthem for a good deal of time, they continue to beat the rates and have the highest network spread in the state at this time. But we are constantly looking at that. That's very important to us. We don't want to be stuck with one carrier if it's not the best for the state.
Have you ever, one follow-up, have you ever looked at, kind of building on Senator Bailey's question, offering different carriers for different areas so the network adequacy would meet certain people's needs, like maybe in Kittery, Blue Cross Blue Shield has a great network adequacy, but in Paris, maybe a different policy that community partners might have. So I'm just curious, have you ever had the discussion of including different carriers as options?
Not to my knowledge. I think one of the things the Health Commission has looked at is consistency and trying to have the same access across the state, but not to say that's not something that they could, could look at as well.
Thank you. Representative Foley.
Thank you, Madam Chair. I'm just curious, how long is the contract that you have? Is it 3 years, 5 years? Do you go out to RFP every year or?
So per statute, we can have a contract with a carrier for up to 6 years. We typically do a 3-year contract with 1-year renewals, but we may, at year 2, if it's advantageous to us to do so, to go out to market for, to see what's out there, to see if we can get the best rates.
So what is the current contract status?
We are coming up on year 3.
Okay. Thank you. Representative Clucci.
Thank you, Madam Chair. Because we are such a large group, I mean, and I don't know if it's, but at like 26 to 28,000 members, would it ever be possible that we could just sort of set rates at a certain sort of percent of Medicare or main care, and therefore, I don't know, maybe like say control costs by setting rates and maybe not necessarily have to rely on a third party administrator to do that sort of negotiation for us?
That's a great question, probably a longer important discussion than to have just like in my response today. However, I think that there is a great deal of consideration in who would still negotiate those rates, because they would have to be agreed upon at the health systems. And I've had meetings with some of the health systems, will say that their costs are going up to manage the care. And so that they need to charge or have the rates that they have in place right now. And I think it's an important question, though. There's many other entities, and the Healthcare Purchaser Alliance is also looking at cost and quality across the state.
Representative Arford.
Thank you, Madam Chair, and thank you again for being with us. Along that line, in terms of negotiating, because we are a self-funded plan, you negotiate with our third party. Our third party administrator negotiates with the providers, correct? On our behalf.
Yes.
And so if it got to the point, let's say we did something like price setting, and let's just say that some of the provider organizations said we can't function with that price. And so therefore, would they, by statute, And by rule, could they withdraw from our network? Is there anything that compels providers to participate in our network, or is it just by choice?
So the network that we currently have right now is through Anthem. So it's Anthem's network and
Okay.
they have agreements with those health systems and providers.
I know, but if we, so we would be potentially the only entity, I'm just following up on this price setting idea. So we would be potentially the only entity, and we're a large entity within Anthem's, all the people that are part of their network, that all the members that they serve, I'm speaking about, that would be party to this price setting scheme, whatever you want to call it. We'd be the only ones that would be doing that. So therefore, would it be possible for providers to withdraw within the Anthem, the whole Anthem thing, and just say, we don't want to contract with the state employee health plan anymore because they're not paying us enough. We can't function. We can't stay in business on them. I'm just saying, would it be possible for them to pull out? Or are they compelled by law or rule or statute to stay in there with us?
Yeah, I would say it's probably a contractual relationship in this hypothetical question. And so it would be part of the contract. If they wanted to break their contract to leave the network, again, it's hypothetical, then that would go to a contract decision.
Great.
But we do have providers in our current network that will, when their contract expires, they choose not to renew. And so then they would fall out of network in current state. And I will say other large employers across the nation, they may direct contract with the hospital to get the best rates. And so all of their employees would go just to that hospital, but they've negotiated, a lower rate and it's ideal for them. But in that case, their employees are usually concentrated in a certain area close to that health system. We are spread out across the state.
All right. I think
Good.
if you want to continue, yeah, thank you.
Okay, and I want to be mindful of people's time. Do you want me to kind of skip over some things? Because I think we're after 11 right now, or am I okay?
Just proceed. Yeah,
Okay,
you're
I will
doing a
do
good
so.
job of just highlighting, I think,
Okay,
so.
all right, very good. So we talked a little bit about LD 2148, and I'm going to move on to page 11 of the report. And this to me is some of the interesting stuff, some of the work that the commission has really dug into. So the commission is always looking at ways to increase the value of the plan and to connect members with important resources. And in some cases, we've been the first in the state to try and implement new strategies. So past commission decisions to engage members have proven very successful. Our decision to align with Carrum Health has proven to be beneficial. Since implementing the Carrum Health benefit in 2019, the demonstrated return on investment for the data reported by Carrum, and I want to point out, and it's noted in the report, independently validated by both the Healthcare Purchaser Alliance and our plan consultants locked in. So in other words, we didn't take just what the vendor gave us at face value. We also validated the ROI. So with the vetting and the additional review, which does support the State Employee Health Commission's fiduciary responsibility, we still did see an ROI with our 2024 Carrum spend data with an estimated total savings of 1.57 million to the plan with an ROI of 10-1. So the state of Maine does have claims data that's shared by Anthem. And I mentioned earlier today, the Healthcare Purchaser Alliance of Maine and Lockton help us look at data and stratify the different components of our plan. And so with that, I'm going to just go over, and these are going to be on the next several pages, some of the strategies and the data points that we're using to move forward with what we're calling approaches or opportunities. So it may not come as a surprise to you all, but cancer is the second condition driving spend with our plan at 23.5 million. And we are seeing an increased prevalence. And just a couple national data stats to level set about cancer. So 17% of cancers are misdiagnosed. 53% of emergency room department cancer-related visits were avoidable. And 44% of those visited the ED in the year after their cancer treatment ceased. And the data sources references are in the report for those stats. So thinking about how we can best support our membership and look at cancer a little more closely, we did launch a partnership with Dana-Farber Direct Connect in 2021. We also launched Carum's Cancer's Center of Excellence in 2025. We're evaluating the same program's Cancer Advisory Program. We're also looking more carefully at our cancer screening data to further identify opportunities. And we're going to collaborate with our Wellstar Me vendor to see about how we can better remove barriers that may be perceived or individuals may be experiencing around cancer screening scheduling. So that's one strategy. Another significant cost driver for the plan is MSK, or musculoskeletal, and it is the number one driving spend at 24.8 million, and it's also seeing increased prevalence. Part of this are back surgeries. A stat that you'll see in the report is indicating approximately 50% of back surgeries are effective, and we all know orthopedic procedures do add up. They have an expense, and that studies show sustained PT can be proven more successful in some cases. So we did launch, as I mentioned earlier this morning, a program with Carum, the Center of Excellence. There is that requirement to first go through Carum. If someone is not a great candidate to go through Carum, then they would just go through the Anthem network. If they go through Carum, they would have no out-of-pocket cost, and the plan would experience a savings on average of about $25,000 per surgery. So in many scenarios, it's great for the member and it's great for the plan. We also launched a digital physical therapy program through Hinge Health in 2022. We've been doing some analysis of this program, and it is showing that those that are participating compared to those that are not participating have fewer surgery visits, costs, and images. So Hinge Health is a digital physical therapy program, which in 2024, 2025, we did some analysis from participants, and you'll just note that the outcomes from the members that did participate in the survey reported a 48% pain reduction, and there was a 20% reduction of likelihood of surgeries for those that engaged, with a projected savings of $721,516.
Yeah, Representative
Yes.
Ostrowski.
Thank you, Madam Chair. Can you just explain to me, I mean, I think I know what you're talking about, what digital physical therapy services are.
Sure. Yeah, so you would use a smart device and you would connect to Hinge Health, and they would guide you through physical therapy. And the system is really cool. If you had the opportunity to use it, you would see that the smart screen mirrors your body. And as you're doing the movements, it's picking up your key joints and movements to ensure that you're doing it correctly too. So it's guided. It feels very innovative.
So they
and
can do it
modern.
at home
You can do it at home.
by yourself, nobody watching you.
Right. Just the coach. Yes. So
Okay.
it saves on travel time.
Right.
It's no out-of-pocket costs.
Wonderful.
So otherwise someone would experience travel and the copay for specialists. So.
Right, Representative Clichy.
Thank you, Madam Chair. Does the digital Hinge Health app connect you to a person?
Yes.
Okay, so you're actually sort of working with a physical therapist.
Physical therapist.
So it's like a
certified.
digital physical therapist. And what is the cost per person?
I may not have that in front of me, but I could supply that. It's no out of pocket for the member, but to the plan. I
Yeah.
can get that information.
Yeah, because I was curious because when I was actually looking at whether or not I should move on to the state plan, I was looking at the the cost of PT visits or OT visits. And one of the things I saw that I think that the state employee plan right now, it's like, if you're in network, it's like $60 per visit.
It's not $60.
It's not?
No, it's less than that. So we have co-pays that range from like 25 to like 40 depending, and then the which I don't have it in front of me. I'm so absorbed in this information today. But then of course for our prescription co-pays, those could be upward cost as well.
Okay.
Representative Arford.
Just, I'm personally engaged with physical therapy, so I'm comparing this to my experience. So the 356 members that take part in Hinge Health out of our entire membership. So that's like, what, less than 1%? It's a very small percentage,
It's a small
right?
percentage.
So then of those, though, how many did fill out the report that you're then saying includes reporting through the Hinge at 48% pain of that 356, how many actually
I can get that
reported?
number for you.
Yeah, I'd just be curious.
Yeah.
And I'm trying to understand the relevance of that 48% pain reduction compared to what? Like if you're having traditional physical therapy, what are members reporting their pain reduction is from traditional physical therapy?
I don't know.
I'm
if we have
just,
that
I don't know
data,
if that's a
but-
good number or a not good
So
number.
It's based on the, say, start of the process, from what I understand. So their pain level at the start versus completing with Hinge. So not comparing to another program, but their own pain
Right.
levels.
So just trying to get a sense of the effectiveness. And the other thing I'm curious about, what's the cost of this program to our plan? Because that's critical. I mean, how much are we paying for the plan? How much are we paying for traditional physical therapy? And then also oftentimes people just get better on their own. They don't do anything and their pain subsides and they actually do get better. So, I mean, do we have data that compares these different options once you're experiencing some sort of pain or some sort of something where your provider recommends that you receive physical therapy?
So we would have data from PT claims, and we know how much we pay Hinge Health. I don't have that in front of me, but I certainly can supply it.
Yeah.
And then you could have the comparison.
That's just one of the things I'm always curious about with all these programs, like how much are they actually costing the plan? They may have a significant benefit,
Mhm.
but if they also have a significant cost, we need to be able to understand that relationship.
Yep.
Thank you.
Understand. Yeah. Okay.
Representative Cushion.
Thank you, Madam Chair. Are the physical therapists that are working for Hinge Health located in Maine?
No, they're all over the country. Okay.
Do we have an interstate compact that allows that? I guess.
I'm sorry, can you repeat the question?
Representative Clucci is just wanting to make sure that those physical therapists are allowed.
Allowed to practice in Maine, I
In
guess.
Yes, per our contract, it's been reviewed, but I'm happy to have that as a takeaway for just extra assurance.
Okay, thanks.
Because I'll say too, some of the providers, not just Hinge specific, that we work with though are licensed to practice in multiple states, because we use like Live Health Online through Anthem, where it's remote service, where a provider would be in another state and they're able to treat a member in Maine, just as a separate program person.
Okay, Representative Mastraki.
Thank you, Madam Chair. In response to Representative Arford's question, I'm just thinking that you did talk about the return on investment, which is the cost of the plan and what it saves. So you're doing that kind of evaluation on an ongoing basis
We are.
for everything that you do.
Yes, I just don't have those numbers.
That's fine. I just think that we should be real clear that it's, yes, you have, the data is really what we need to know is what's the return on that investment?
Mhm.
Not how much it cost here and how much it cost there. Did it save or didn't it save? Because it seems to me you're not going to keep doing it if it shows it doesn't save any money.
Yeah, so you will see in the report, it does have a savings of $720,516.
Representative Arford.
Thank you, Madam Chair. And again, thank you I don't want to belabor the point, but a return on investment, a savings of I'm still interested in compared to, I mean, a saving speaks for itself. However, I'm still interested in compared to what?
Okay.
Like, what is the return on investment for traditional physical therapy? And that type of thing. It's just trying to understand. It does seem like it doesn't seem like a great number of our members have taken part, just for instance, in the Hinge Help, a percentage of members. So it's a return on investment for that number of people. And it's just sometimes the data itself can not tell the full story unless you have more data to compare it to. So that's where I'm going with that.
Yeah,
But I mean, I'm not asking you to spend a lot of time on this or anything. I'm just curious to see how this all plays out.
yeah, this group looks at data. They look at reports every month. And so it's something we probably could pull together. Welcome.
All right.
Okay, so just gonna move along, page 13 out of 16 pages of this report. So nearing the end here. Also noted as a strategy is the health premium credit program. And many of you may be aware, if you have our plan, it is something that is in statute, and we outline criteria for people to achieve on a yearly basis. And if they do so, then they receive 5% discount on their health premiums. And we look at this data and it does help us further strategize more potential programs or even sometimes pilots with the wellness programming with that data. And you'll see in the report participation in the health premium credit by years from 2020 to 2025. Just notable in 2020, we had about 6,500 or so individuals that participated in the health premium credit. And in 2025, the number has increased to 7,340. A couple other things, programs rather, moving on that we have opportunities, approaches, is Wonder Health. Now, this is a virtual online resource that provides weekly education to members that enroll, and it focuses on clinically proven behavior change and nutritional information. We have seen a decrease in participation in this program. The data is showing us that this is something that, while it seemed to be popular and potentially work at the time, I think we have other programs that we're seeing would be more effective. So we're looking to phase out of this program in the 2026 and navigate people if they choose to some of the other programs that I'm going to talk about on the next page. We do have a couple programs for diabetes management. We'd have a population within our health plan that can really benefit from diabetes management services. So the Livongo by Teladoc Health is one program. These services are offered to help someone manage their diabetes, and enrolled members do get access to glucose meters and supplies. They get automated readings of glucose meter testing and clinical coaching and direct was there a question? Direct contact from the coach. So the other thing that people like about this program, and I won't spend a lot of time on this, but they can connect this information to family and friends so that they can be alerted if they get into dangerous levels of low glucose. So that is a feature that has been very popular, and the technology is very sound in this program. Moving on to page 14 of the report. We also have Virta Health, and there's two different programs with Virta Health. Again, diabetes program. This one is type 2 diabetes reversal. And there's a lot of evidence with this program. It's relatively new for us, and we launched it in 2024. But we have individuals with type 2 diabetes that receive intense nutritional management combined with health coaching. They get a clinical support team, which is online. And this does help participants sustain weight loss and look at behaviors, and in a good amount of cases, move away from needing to use medication for type 2 diabetes. And you'll see in the report, the numbers are low. It's a program that we just launched, but again, it's a low number, but it's also a subset of our total population that would be eligible for the program. Another program that's offered by the same company, Verta Health, is the weight loss management service, which we found to have stronger evidence than the Wonder Health program. This is a behavioral health change. It's virtual. It is an app. It's intense nutrition management. Again, that has a clinical team, a health coach that connects with participants. There is materials that are sent to a participant, like a Bluetooth scale, some, clinical, medical monitoring, as well as a starter kit to engage in this program. And I think that was my last program that I was giving a bit more overview on. So I think that concludes my review. I want to thank you all for your time today, and I have a couple takeaway questions that I'll bring back. And if there, yes.
Representative Olson. Sometime.
That's, I've been silenced before, but this, I think what may be helpful is some of the questions that came up was when we're talking about the CPI increase and whatnot versus decrease in benefits and whatnot. If you could bring something that shows when the CPI increase did not allow you to meet your cost goals, you had to lower benefits. So kind of a chart that shows when that happened, what benefits reduced, and then how that mirrors to what's happening out in the rest of the world as far as the large group and small group plans.
Okay.
Additional questions from committee members? Representative Orford? I'll turn.
Thank you, Madam Chair. I know it's probably in here somewhere, but I'm very interested in how many, because we've had requests last year we had quite a few, and we came up with some criteria for onboarding other groups that are non-employee groups. But I'm curious as to how many groups and what if you have this data, the groups that have been onboarded, let's say in the last 5 years or in a short period of time, and how many members that comprises. And do you have any sense of when members come on board that are not employees, they're not Maine State employees, they're paying all of their own costs, right? They get the same benefit package, but they're paying their own premiums. There's no subsidies for them. Is that correct?
So it probably, I'd have to get a little bit more granular for that question to fully answer it, because there's so many variances in terms of the payment structure. But if you look at page 8, it does have some criteria of what was looked at, and there's 31 ancillary groups that are participating in the plan at this time.
And do we have any sense at all about whether that benefits the plan financially, or whether it does not benefit, or that it's a wash? Do we have any data on that?
We have looked at some data over the years. Some would say that if you have more numbers on your plan, it gives you leverage, or the choices that you make may steer the landscape, in our case, for the state and the health system. So there is some significance to volume, but then you also run the risk, because with more people could come more high cost claimants. Those things are also unpredictable, and high cost claimants do drive up the plan. Our stop loss kicks in at about $750,000. So the plan pays $750,000 claims.
That's why at some point I think it would be helpful to see that data, to see how in fact has it impacted the plan over a certain number of years. With, you look at the new member cost, not the new members that are not state employee cost, the state employee cost, you compare that. I'm sure you've done this analysis, correct? Because there's always the possibility of, if it looks like there's an advantage to that, that we might want to look at opening it up, right, to more people. I mean, is that ever a consideration?
I think that other entities find our plan more generous than some of the plans out in the marketplace, so it's desirable to them, but it is not without risk.
I understand, yeah. Okay, thank you so much. This is excellent, by the way.
Thank you very much. I
Thank
just
you.
wanted one real
Oh,
quick
okay.
question. With all of these different plans, wonder that you're discontinuing the Livongo, Virta Health, are those mostly offered through the third-party carrier, or how is that? Like, how do all transparency, I'm a dietitian. So when I see intensive nutritional management, I go, who's doing that intensive nutritional management along the lines of what Representative Clucci said? So I'm just curious, where is Virta Health through? I mean, is that through Anthem, or where is that located?
It is a separate entity. It's a separate company. And so I'm happy to give you more information because that's a vendor that we've been really pleased with. We've got a lot of positive feedback. So I could take that as a takeaway.
I don't need to turn mine off because I'm still sharing. Additional questions? Yes, Representative Clucci. Oh, yeah, I do have to turn.
Okay, so two additional, because this has been really helpful. Can you remind me your name?
Oh, yeah. Yes, it's Shauna Poulin Gutierrez. That was an easy one. That was the best question.
Okay, and then the last thing is, it sounds like, like so many of these, like this preventative work seems awesome. But I'm wondering if maybe if there's not apps that are right for everybody, does the plan also pay for like lifestyle medicine, physicians and services?
I'd have to look more closely to specifically what you're asking, like with a specific.
Like in person, like doctors that focus just on, helping people with weight loss and exercise planning, just like in person, because not everybody is going to do well through an app, right?
Yes.
But there are physician practices and non-physician practices out there doing this. And so I was just curious whether or not the plan covers that as well.
Yeah, so that might be something where we'd have to look more closely into the network to see where they lie, but we do cover registered dietitian visits at no cost. So there's no copay. We've always really tried to encourage people to connect with that, key foundational information for good health. So there's no copays for registered dietitian visits.
Thank you. Additional questions? Seeing none, thank you very much for your
Thank you.
time.
Now we have our presentation by N Coyle. I'm not sure who's here. Well, please come forward.
I do think they have some slides, which I'll project for you, but they have hard copies as well. so-
Great. Thank you for your patience.
Give me a seat if you're on in. I'm going into the. Last name. No.
Yeah, absolutely. I totally get it.
Oops. Sorry. Okay. Whenever you're ready.
Okay, well, good morning, everyone. I think we're still in morning, just barely.
Yeah.
But thank you, Chair Bailey and Chair Matheson and members of the committee for having me here today. I'm Will Malofchik. I'm CEO of the National Council of Insurance Legislators, NCOIL for short. and really happy to be here to help explain a little bit more about NCOIL for those of you who may not be familiar with the organization and to encourage Maine's participation in it going forward. And special thanks to Representative Foley here for really helping to facilitate this after his attendance at some of our recent meetings. So a little bit of, I hear an echo.
Yes, there is an echo.
I think if that computer gets turned off.
Oh, that one, you
Yeah, I
think?
think that one. I think we're gonna go there.
Okay.
We'll try it now. That sounds pretty good. Thank you. So just a little bit of background on NCOIL. So NCOIL was founded in 1969, and we are a national bipartisan legislative organization that's represented principally by legislators like yourselves who serve on their committee with jurisdiction over insurance and financial services issues. And NCOIL really is a unique organization. We are the only organization of its kind that is national in scope, that is bipartisan in nature, and that is comprised of legislators and that develops model laws focused on insurance and financial services. So when you put all those things together, there is no other organization of its kind. And speaking of model laws, some of our model laws have been very successful throughout the years. One we always like to point to is what we call the Transportation Network Company Model Act. So many years ago when Uber and Lyft became a part of all of our lives, an insurance framework had to be set up to deal with those companies and to provide consumer protections. So NCOIL developed that model act that's been adopted by almost every state. And a couple of other examples include a credit model, which governs how insurers can and cannot use credit information in underwriting. That's been adopted by well over half the states. And more recently, there's been a trend for states to require insurers to cover biomarker testing. So that stems from an NCOIL model as well. And NCOIL really has two main missions. One of which is to preserve the state-based system of insurance, which was actually established by Congress back in the 1940s, which I'll touch on in a little bit, and then really to serve as an educational forum for legislators and interested parties on what the current and the long-standing insurance issues are. And as you can imagine, in a time like now when there's so many issues facing the marketplace and consumers, the value in participating is stronger than ever. So just a little bit about our structure. So all 50 states are members of NCOIL. And then there are about 30 to 35 states, it fluctuates year to year, that are termed contributing states, which means that those states pay the organization annual dues. And Maine was a member state several years ago, but for a lot of reasons due to things like term limits and retirements, kind of the institutional knowledge of NCOIL gets unfortunately dropped. And so the membership drops. And so we often return to states like I'm here today to encourage that membership to restart. And there's a lot of benefits that come from being a contributing state. One of which is participation in what we call the stipend program. And the stipend program works that we have 3 national meetings across the country per year. And for each of those 3 meetings, there's 2 stipends available for legislators and staff if no legislators come, which covers the registration fee and up to $1,500 in expenses. And I'll touch on the return on investment on that, but that really does make it worthwhile because the stipend money actually comes directly from the dues payment. And also another benefit is only legislators from contributing states can serve in our leadership ranks, our officers and our chairs and vice chairs of our policy committees. And then we also have a policy practice of only holding our meetings in states that are contributing states. So going to return on investment, when you factor in the economic activity of one of our national meetings or our smaller regional meetings, and then the stipend program, which that money comes from the dues payment, the ROI really is worth it because the dues are a reasonable amount of $20,000. And when you compare that to other organizations like NCSL, which I'm sure you're familiar with, which is, a great organization, but I know that the state dues vary by population size, but I know there's significantly more than that. So when you factor all those things together, the states that have maintained their contributing state status really do think that the ROI is worth it. And I will say there's been a lot of interest in NCOIL having one of our meetings in Maine. So we certainly would be open to looking at that. So as I mentioned, we have the majority of our work goes into putting on these 3 national meetings across the country, spring, summer, and fall. You see the dates there in your slides for this year's meeting. Will be in Louisville, Boston, and Florida. And during these meetings, we have separate policy committees broken down by each line of insurance. So we have a health insurance committee, life insurance, property and casualty. And the members of those committees are state legislators like yourselves. And they discuss and develop model laws and hear educational presentations on what the current issues are. And at these meetings, we're averaging currently about 400 total attendees, which consists of about 70 legislators from over 30 states. We usually also have anywhere from 5 to 10 insurance commissioners participate. And then the rest of the attendees consists of insurance representatives from all lines, trade associations, consumer advocates, attorneys, and lobbyists. And that really forms the basis of the attendees. And right now, it's a great time to be involved in NCOIL. We're really on an upswing. As I mentioned, the 400 attendee mark. We actually, last year, we broke the 400 barrier for each of our 3 national meetings, with our annual meeting being the highest attended meeting ever. I think the tally was about 415 people, which Representative Foley was one of them. And an important aspect that I mentioned earlier, but NCOIL, really, we like to stress that we are bipartisan in nature and truly representative of America. And at these meetings, we're really focused on policy discussions and not politics. And often that's really what you hear a lot from the legislators who attend our meetings, that they enjoy learning so much and, putting all the noise aside of a lot of the things that you deal with in the legislature that aren't associated with policy. And oftentimes you'll hear legislators come to our meetings, and after coming to a bit and developing relationships, they won't even know the colleagues that they're talking to, whether they're a Democrat or a Republican, because we're really just focused on insurance policy. And we have a kind of a built-in mechanism to protect that, where we alternate the political party affiliation of our president every year. So last year was a Democrat from New York. This year is a Republican from Minnesota. Next year will be a Democrat from Louisiana. So that really helps preserve that bipartisan nature and that focus on policy. And there's a slide there that lists some of the issues that we're currently talking about, or we have been talking about. I'm sure a lot of those are very familiar to you that you've dealt with in this committee. A couple I'll note that I know you definitely have focused on and are great examples of kind of the issues that NCOIL works on is the Strengthen Homes program, where grants are afforded to homeowners to make improvements to their roofs and houses, and sometimes insurance discounts are associated with that. So we spent a lot of time bringing in interested parties from states where that's worked. We've developed a model law on that's been adopted by several states since being adopted by NCOIL. Also, I saw on the committee's agenda, I don't know if it's after this or earlier, the issue of earned wage access providers. So that, I'll just say good luck. But that's an issue that NCOIL dealt with. We spent almost well over a year actually bringing in parties from both sides on developing some model guidance for states to use. I looked at the bill that you're considering, and there's a lot of similarities with the NCOIL model as well. AI, I'd be remiss if I didn't mention that. There's kind of 2 types of AI that we've been working on, artificial intelligence being the most obvious one. We've been discussing a concept of trying to require a qualified human professional to review any claims denials or adjustments that are made by algorithms. And really what that started from is on the health insurance side of things, that type of policy actually has been adopted by some states in the prior authorization space, where some states have said that only physicians can make those types of decisions. It can't be AI. So what we've tried to do is see if that makes sense to apply across all lines of insurance, so life and P&C, really just to make sure that there's a human in the loop on these decisions. That's proven to be very difficult because, as you know, the lines of insurance do differ dramatically, but it's something we're trying to work on going forward. And then the other type of AI is aerial images. And that's been a big issue several states have dealt with, where insurance departments and legislators have received some complaints about homeowners having their policy canceled based, or non-renewed, I should say, based on aerial images that were taken of the home that were sometimes proven to be inaccurate or outdated. So a lot of states have tried to develop some guidance, which we have as well, to provide the homeowner some. Is there an interested party back there?
I'm getting a little nod, so I'm thinking we did something. Okay.
So trying to provide the homeowner some rights to at least provide evidence of, hey, that picture is outdated or you have the wrong house. So that's an issue that we are that is an issue for sure. And so I won't go through all those issues, but those are just kind of illustrative of what we talk about at NCOIL. And you know, when I go to states and kind of talk about NCOIL, I do like just to spend very briefly providing a little bit of history on, you know, how we got here with insurance regulation. So it actually all starts back in the 1940s. There was a Supreme Court decision that said that insurance was not interstate commerce, and thus it wouldn't be federally regulated, which frankly didn't make a lot of sense. But then a few years later, a Supreme Court case overruled that and said, no, it is interstate commerce, so Congress can regulate it. But if you look at the dates around there, Congress and the country was very busy with World War II and basically said, okay, well, we're going to pass something called the McCarran-Ferguson Act, which says that unless that Congress expressly steps in and says we are regulating this, the quote unquote business of insurance is delegated to the states. So you might be thinking, well, what about health insurance in the Affordable Care Act? So Congress can, under McCarran-Ferguson, still step in and regulate insurance if it wants to. The ACA and health insurance being a good example. But absent that explicit law from Congress, there's been a policy decision to say, okay, the states are going to govern insurance. And that leads us to today, where states by and large regulate everything with insurance regarding investing, licensing, company formation, and legislators such as yourselves pass the laws, regulators administer them. There's the mention up there about the National Association of Insurance Commissioners. Great organization, fully supports the state-based system. But it's important to note that there, as the name indicates, is a regulatory organization. So again, NCOIL really is unique, where we share a lot of interest with the NAIC, but our members are legislators, and the organization is represented principally by them. And one example I always like to mention too, just to highlight an issue that a lot of states are facing, and that something that NCOIL is trying to solve, deals with ERISA. So I'm sure, as you know, on the health insurance side of things, you've dealt with a problem where, if states try and pass a health, the best example is a mandate, not necessarily supporting mandates, but if a state makes a policy decision to say, insurers should cover this benefit, in reality, that policy decision is really only affecting a tiny percentage of your state's population, because ERISA has expanded so dramatically that it really governs the lion's share of the marketplace. And NCOIL has taken the position that That's really beyond the intent of what ERISA was enacted for. It really was enacted as a pension plan act, but it's really expanded dramatically. We have numbers going back to around 2019 where it really governs almost 60% of the marketplace. So what we've advocated for is similar to waiver programs that exist on the federal level with 1332 programs and 1115 with Medicare and Medicaid, where states, if you're looking to adopt some sort of health policy initiative, you could apply to federal agencies such as Health and Human Services for a waiver. And as long as it's shown that the benefit will save costs and other things in the long run, then that would apply to the entire state's population. And we've gotten close. To that bill almost being introduced, but it stalled at the last second. But that's something that we continue to advocate for, and we'll also weigh in occasionally with amicus briefs at the Supreme Court level. And the last slide you have is just some other examples of what we think is federal infringement on the state-based system. The one that I'll just quickly highlight is the recent activities regarding artificial intelligence. There were attempts to implement a moratorium, a 10-year moratorium on state regulation of AI, but NCOIL pushed back on that, as did the NAIC, and that ultimately was withdrawn. But recently, you may have seen the administration's executive order aiming to attempt to preempt states' ability to regulate AI. That we think is we pushed back. We do think states. The executive order really wouldn't impact legislative efforts, but that's something that we're examining, and I know a lot of attorneys are as well. So I'll stop there. Thank you so much for the opportunity. I'm happy to take any questions, but thank you again for having me.
All right, thank you. Questions from committee members, Representative Foley.
Thank you, Madam Chair, and thank you, Will, for coming. I really do appreciate it. And Patrick back there for making the trip up to snowy Maine. Although they came from New Jersey, they have more snow in some parts of Maine, and they're probably going to get hit this weekend, and we may not. But anyways, I really want to thank him for coming. I've been going to NCOIL, been participating in NCOIL since 2015, back when we were a member state, and I've gone to many of the conferences over the years, and I have to tell you how valuable NCOIL. Just for instance, last year on our 340B program, I gained an awful lot of information from a meeting last spring in Charleston that helped me work through the process and get us information. So we passed a very comprehensive 340B bill, but based on a lot of the information that I got from that meeting. And so I really, since I'm retiring from the legislature, I really encourage the members to get involved with NCOIL. The stipend program is great. The facilities that they have in are just super. And the camaraderie that you get from other legislators and from other folks that are there, it's just really a very important opportunity for you to get more information about what's happening in other states, sharing information. And so I do hope that the state, and we will have to visit that again, that the state does join NCOIL, because I really think that Maine would be a great place to have one of the regional meetings. And I hope some folks will take some information, contact NCOIL, try to go to. I'd like to be going to Kentucky this spring. Since I'm retiring, I don't think they would want to have me there, but I think it's just valuable. And so I really appreciate Will coming up, spending the time with us, and Patrick as well. So thank you very much for indulging us and letting us have this presentation.
Thank you. Further questions?
Yes, I'm sorry.
Good. Representative Arford.
Thank you, Madam Chair. And I just have to second, thank you so much for coming up here. I haven't had the type of engagement that Representative Foley has, but I've seen the value of him being engaged and bringing the information back to us. So I'm really grateful. I just wanted a quick follow-up question about, you made the comment that, insurance management administration is primarily left to the states, but I have not experienced that really to be true in the healthcare realm. Is healthcare treated differently than maybe the other lines of insurance? Because the federal government, first of all, the federal government has their own Medicare program, but still, it seems like, they regulate really Medicare, they regulate the exchanges. I mean, what's left to us is we work with, but can you just speak to that?
Sure, and that really goes back to the McCarran-Ferguson Act that was passed in the 1940s. So it doesn't completely grant a blanket authority to states to regulate insurance. But what it says is that unless there's a specific act of Congress that says we are going to regulate this aspect of insurance, then if a federal agency tried to implement some sort of health policy reform or on the life insurance side of things, then that would actually be preempted. It's kind of called reverse preemption in a sense by the states, since they were granted insurance regulatory authority pursuant to McCarran-Ferguson. So with things like healthcare, that's the most obvious example of that. Obviously required congressional action to pass laws to say Congress and the federal government is going to regulate health insurance. So that's why they have the authority there. But life insurance, property casualty, those are predominantly regulated by the states.
Thank you very much.
Sure. And just one thing I'd like to quickly add, I mentioned the stipend program, of helping facilitate legislative participation to cover travel expenses. While states are considering joining NCOIL, we have another mechanism, which is our scholarship program, which is kind of meant for legislators to try out NCOIL while the state is considering membership. So we understand it's not as easy as just flipping a switch and joining. So while Maine considers the membership, we do have scholarships available that are limited to about 2 or 3. It's kind of a way to incentivize membership. So, we'd encourage, if you're interested before any decisions are made by membership, to reach out to myself or Pat here about that program.
Great.
So I did have a question, well, a comment and then a question. My comment is that I know when I've gone to other conferences by other organizations that what I find invaluable, and Representative Foley, I think, hit upon this, is just the connections you make, the networking. You talk with a legislator from Colorado that, you would have never run across in the hallways here in Maine. So you really learn a lot from each other, but you also meet people that you then have as a contact, and an issue comes up and you're like, wait a second, I remember meeting this legislator from Louisiana that was working on something like that. Kind of along those lines. So one thing that I really enjoy with some of the conferences I go to, the most recent one was a NASHP conference, which of course is focused on health insurance, but they do a members only day where the lobbyists are not allowed, and you can
Big smile on your face.
sorry, you're the only one in here at the moment. So,
There's
but
2 more in the back. You can't.
oh,
see.
okay. But it just, again, it allows you to have discussions and whatnot, just, amongst yourselves, so to speak. Does NCOIL set up their meetings that way as well?
Yes, there are certain opportunities. So the majority of the conference programming is dedicated to the policy committees that I mentioned, which are open to all the attendees, and they kind of function purposefully since we're a legislative organization, similar to a legislative hearing, where we'll bring in both sides of an issue. And if it's a model law, they'll debate it with the committee, or if it's just an educational presentation, they'll hear from both sides. But there are other opportunities, usually focused on breakfast and lunch, where it's just the legislators, and they hear from an organization we have a partnership with called the Griffith Foundation, that is non-advocative in nature and just provides education on certain issues. So no one else is in the room besides the legislators, and that's an opportunity to talk about what's worked and what hasn't worked in the states.
Thank you. Any other questions? Representative Mastracchio.
Thank you, Madam Chair. And it really isn't a question, and I will just say up front that I think that these kinds of groups, but in particular ones that are nonpartisan, that really do give you the information that you need for the issues that you're facing. And I'm looking at your model laws. I mean, you have a lot of really good information on your site. And I do think that for legislators who are planning to stay on a committee like this, that it would behoove you to take advantage of this, because you're just reinventing the wheel if you are starting from scratch when you can start from this. So thank you for coming today. I really appreciate it.
Thank you.
Further questions or comments? We're all getting hungry, so this is perfect. So are we going right to Ledge Council? Is that the plan?
Yes,
Representative Foley?
lunch is already sitting over there waiting for us. So we're in Ledge Council chambers. So make your way over there and we can have some lunch and chat and have a little bit of free time.
Okay, great. All right.
Thank you very much.
So.
Thank you very much.
And we will be back
Yeah.
at 1:00. Right.
Hey, how are you?
Earned wage and census up to same.
So
that was why I was like.
Are you
having fun? I'm a lawyer. So I represent the PNC and health issues for 39 years. So really involved, but you guys do great work. I appreciate it. So, it's been helpful for. Yeah. All right.
It's a great.
Don't worry.
It's on. Right here.
Good afternoon, everyone. Welcome back. Continuing with health coverage, insurance, and financial services. And this afternoon, we have a number of work sessions on some carryover bills. Just for the committee, understand that these bills, we are supposed to vote these out by the end of the month.
28 today. That's today.
So I'm just putting that out there that, this is kind of crunch time in terms of just making a decision which way we want to go with all of these bills. And with that, we will start with LD 519. And this is Representative Morris. This is the Magara bill. I don't know, Colleen, if you have any further
I can just
information or.
reorient you, I guess, to where we are. You'll recall that last week, the Bureau of Insurance presented the analysis that was prepared by their consultant, looking at various options with regard to Magara and focused on some possible changes that the committee might consider in terms of the funding for Magara. So I think that's one of the things that the committee might consider, whether or not to pursue some of the scenarios that the Bureau provided as part of their analysis. You do also have the original bill, LD 519, which as drafted would propose to undo the merger of the individual and small group markets. That's the proposal as put forward in the original bill from Representative Morris. And I think Edna, I'm not sure if she's handed it out yet, but we got some additional written information on LD 519 from some of the interested parties.
Yes.
Or she could hand it out now, I think. You already did? Oh, okay. So it should be in there. Okay, great.
Yes.
So you have some further information from Anthem. You have some follow-up information from the Maine Association of Health Plans. I think there's a letter there from the Maine Education Association Benefits Trust, as well as a letter from the Healthcare Purchaser Alliance of Maine. Summarizing those, I think they expressed concerns about an increase in the assessment if the committee moved forward with some of those proposed statutory changes, and asked that the committee perhaps take some additional time or look at other alternative funding mechanisms like the general fund, and laid that out in that proposal. The last thing I guess I would say is I do also understand that Chris Howard, representing Magara, is available online if the committee has any questions for him. I also understand he's might need to catch a plane before 2:00. So if you did have questions for him, I would suggest bringing him
Ask
over
them
earlier
now.
than later. Other than that, I'll stop there and I'm happy to answer any questions, but I think this is really the committee's time to kind of think about and talk about possible paths forward, or not.
Okay. Discussion. Anyone have a magic bullet? Representative Foley.
Thank you, Madam Chair. I think one of the basic decisions we have to make is to decide whether Magara is worth keeping or not. And certainly over the years, it's proved, I think, to be a very valuable tool to controlling the cost of health insurance. So I'm not one inclined to want to see it dissolve. I think it's an important, so that comes down to funding.
Right.
I'm just going to I did some calculations over the weekend and just some thoughts about what I thought might be a reasonable thing. So I'm just going to throw it out there. The actuaries,
Discussion going.
the actuaries back there can prove me wrong, but
Oh,
so
there she is.
what I looked at is under the alternative funding scenarios, I took a look at the proposal for going from $4 to $6 per member per month.
So you're looking at page
You're in the
17.
17, yes, yep.
Of the report. Yep.
So rather than go to the $6 per member per month, I calculated if we just went to $5 per member per month. And that, if we did that, the revenue generated by doing that would be, I came up with 7.15 million. And then I looked at rather than going to 3% assessment for the fully insured market out of the general fund to go 1.5%. And that generates around 42.75 million. The long story short, if we add all of the, and you add it to the current assessments, the $4 per person per month, and you add all of those changes together, you raise 147.8 million. And looking at the calculations where they were told that at 10.6 million equals a 1% reduction in healthcare premiums, this would generate about a 14% reduction. Obviously subject to somebody else's calculations. That's just sort of a scenario that I thought about as a way to fund Megara, to keep Megara going. I know there are some that don't find the value in Megara, but for the commercial payers, I think it's a valuable resource. So that's just a starting point. I sort of throw that out there as just an alternative funding mechanism. And I think the 1.5% assessment would be about 42.75 million out of the general fund.
That's my question.
This also, and I tried to calculate, this would also enhance the federal pass-through monies as well.
Right.
So trying to put all that together was where I came to 147 million.
Representative Mastracchio.
Thank you, Madam Chair. Representative Foley, can you just go through that one more time so I can write it all down? Because I'm just trying to figure out, I'm on page 17.
17. So where you see the $6 per payer per month,
Yep,
right now we're charging $4.
right,
So I was calculating, rather than go to 6, go to 5.
okay,
And then under the 3% premium assessment that would come out of the general fund, I calculated at 1.5%
out of the general fund
out of the general,
or rainy day fund.
wherever they want to find it.
Right, just wondered. Okay.
So yeah, so doing all those calculations, calculating the federal pass-through, that's where I came up with the 1.47.8 million, and would be about a 14%, a little less than 14% reduction.
Thank you. I appreciate that. I think I can live with that.
Okay. Further questions, discussion? Representative Matheson.
Thank you for that suggestion. I don't think it was too far away from what I was considering. Obviously, I find this Megara to be the one area where we can really directly see a rate decrease on. So I see the value of this. I just want to clarify that you don't want to do full general funding. No, okay, thank you. But I do support taking money and making sure that this is funded going forward.
Oh, yeah, Representative Foley.
Yeah, and just to clarify, and the reason I didn't want to do that is if we got too aggressive, I wouldn't want it to die on the vine. I think having a shared responsibility, both for payer per month. I mean, the other thing you could look at and say, okay, well, let's have everybody in the main health plan pay the $4 per payer per month, but that doesn't generate the kind of revenue that we need to make a meaningful change. And a 13-14% change in the it would be meaningful. And again, if we decide to go down this route, I would certainly have the department really crunch the numbers for us, because I'm doing it sort of as not an actuarial, just sort of a guy with a calculator. It could be dangerous.
Yeah, I was gonna say, it's the most
I
dangerous.
think I'm pretty close though.
Yeah, and I think AFA will want those hard numbers. And any of us are going to lobby AFA in the value in this, you know, that information will be crucial, obviously. Further discussion? Any other information that's needed? Representative Boyer.
Thank you, Madam Chair. I just want to make sure I'm following along. So you're Rep. Foley saying the 1.5 would not be an assessment, but would instead come from the general fund.
Well, it would be assessment on the premiums for the fully insured market, but money would come out of
The general fund.
general fund.
Okay, thank you.
Which is in line with what a lot of other states do, where they have set fee and general fund or combination of both. Yeah, I was kind of surprised we've never done general fund. Quite honestly, you know, when
And
I started
I-
learning about the history. Yeah.
And I think doing that the combination brings some stability to the market, because we've seen it fluctuate so much. I think that would help bring some stability to the funding mechanism.
Right. Once you see the benefits. Absolutely. Representative Morris. I'm sorry, I thought I saw your hand up.
Thank you, Madam Chair. I was just trying to think it through in my own head. Okay.
I'm glad we could answer that question for you.
Actually, I will. I'm sorry. Early in the day or late in the day. Thank you, Madam Chair. So I did have some other discussions with some of the other interested parties over the weekend. I know there's concern. I mean, no matter, I think as has been said, this is a program that is worth saving and certainly with the potential it has to do. But I know that we have some other folks in the room that may have some other takes that on the issue of sort of what happens with the additional assessment as well as what happens with additional with additional funds coming from the general fund. I guess I know I see Chris Ossenfort's here in the crowd. If she'd like to just sort of give her take on some of this. If she had. Right. Sorry.
No, it's okay. Like I'm in the kids' chair.
Yeah, I know, it's really loud. I tried to raise it, but I couldn't figure it out, so that's why I'm sitting in this one. Sorry. It's the broken chair, so I apologize. I was like, should I get a pillow? Like, there's no way I could do that.
I'll go sit on my files.
Yeah, right.
Good afternoon, Chris Ossenfort with Anthem Blue Cross and Blue Shield.
Landed that way.
Yeah, I know. Thank you. We did submit a letter on, with respect to the different scenarios that had previously been presented to the committee. Obviously, we'd have to take this back and look at what the potential impact would be. As was noted, general funding is consistent with what a number of other states do. The other option, and this was something that we suggested in our letter, would be, McGarrett will continue to have a positive impact. I mean, it is declining. You could also do nothing at this time and take the opportunity to do further study about structural changes to the program that also might enhance its long-term sustainability. So that is another option, is to let the program exist as it currently does for another year while you study other options, because while this does increase the funding, the challenges of the merged market remain. Small group premiums are higher today than they would be absent a merged market. So you have in the small group market, you're seeing premiums go up because of the merger, and then McGarrett has to offset that. So are there other ways that could be, are there other policy options that could be looked at to eliminate that sort of push-pull? We're happy to take this back and look at I'm going back to old days, Representative Foley's proposal, but we would share that perspective as well.
Any other questions for Ms. Ossenfort? Representative Boyer.
Thank you, Madam Chair. Thank you, Chris. I guess I have a question about that statement because of what we received from the Bureau. They said that the merger was intended in part to stabilize the small group market. So I guess I don't understand how the small group market premiums would be lower than they are in the merged market.
Right. So, I mean, I can't speak for the Bureau, but I think the thought behind the original proposal back in 2021, was that putting the small group market in a larger pool would help stabilize it. The challenge is the individual market tends to be less healthy than the small group market. And so that actually drives up the base premiums in the small group market than they would be absent the merger. So if they were separate pools, the small group market is healthier. It would be smaller. But basically right now, the small group market to some extent is subsidizing the individual market. And that was, I mean, I think that was something that was anticipated. I think if you look back at our comments from a few years ago, we said that we saw that happening. I can't remember if the Gorman report, which was the actuarial analysis that was done at the time, referenced that. I'd have to go back and look at that, but this is something that we anticipated would occur.
And so at that time, the trade-off was allow it to continue destabilizing or raise premiums.
I think I think some of our actuaries may not have felt that it was as unstable, perhaps, as it was perceived. I mean, there were a lot of, and I think the superintendent in their presentation last week talked on this, there are a lot of factors at play right after or that legislation passed, including the establishment of, they were temporary, but they were premium tax credits or premium credits for small group plans that the state funded using COVID dollars. That also helped to stabilize the small group market.
Okay. I'm not sure I agree, but I'm not sure there's a point in continuing to go back and forth. So thank you.
Yeah, I'm happy to try to get one of my actuaries to, come to the committee to explain why we believe that this is actually driving up small group premiums. And then the McGarrett has to offset that and then some, but there might be other policy options that could be explored.
Yeah, just because it says here, there's a 25% drop in membership from 2015 to 2019 in the small group market.
And that's with the combination during part of that time. The markets have been merged since 2023.
Okay, thank you.
Further questions for Ms. Ossingford? Oh, she's up there.
Thank you.
All right, thank you. Further discussion? Representative Foley.
Yeah, and again, I didn't mean to spring this on people. I actually did this on a couch during the snowy snowstorm and on Monday. So, but I think that if this is something that we as a committee want to explore, I think it would be important to send it back to the Bureau and to others to just really crunch the numbers to see how, if what I'm calculating is correct, before we vote on it, or vote on it and see what happens. But, I just, I remember, back when we talked about merging the markets, there were a lot of things going on, as Ossingford said. You had the small group market was declining. The individual marketplace was sort of unstable, people coming in and out of main care. There was just a lot of volatility at the time. And so it was hoped that it would sort of stabilize both markets. I think there's been some mixed reviews there, but I think the long and short of it, McGarrett has helped in the long run. And so I think saving it is certainly worthwhile. And the only way you're going to save it and make a meaningful, 14%, when we just saw what 22% rate increases, well, throw a 14% reduction on that marketplace. And that's helpful to the people trying to buy this product. So, that's, again, I didn't mean to just drop this on. It happened on Monday and we're here.
Yep. And we don't know, it might actually pull some people back into the market and, you know, there were those kind of numbers. You just don't know.
Yes. yeah.
Representative Matheson.
I'm happy to make a motion, to pass as amended with the Foley amendment.
Is there a second? Are you seconding it? or you just
No, I have a question.
Okay.
So do we know that the money is even in the rainy day fund for this? Given the fact that we heard last night, a lot of money was going to be coming out of that rainy day fund for different things.
Yeah, and again, we're not designating where it comes from, so this will go to AFA, obviously.
It goes appropriate.
Yeah, appropriations.
If we, we pass this and come up with a physical note, that'll go to the appropriations, and then they would have the discussion of where the money comes from or whether they take it off the table or not. I guess our job is to simply offer it and then, see where, where it shakes out with all the other appropriations. But I think, there's been a lot of discussion with both sides and with leadership that we need to do something with premiums. The premiums are driving people out of the marketplace, and so we have to do something. And I think the lack of other alternatives, this certainly should be one of them for us to consider.
Okay, and so I will second that motion so we can continue our discussion. The other thing I would suggest, Representative Foley, is that, we go ahead and vote on this, assuming it passes. We can ask the Bureau to crunch the numbers and have them for us when we do language review. Obviously, if they come back with numbers that, are just totally different than what we thought, we can always reconsider. But just as a way to keep it moving along. So, Representative Olson.
Just a quick effective date of this would be
January 1st of 2027.
2027, I assume, yeah. Yep. Yeah, Representative Morris.
I think I'm getting my bearings here. Thank you, Madam Chair.
Welcome to the committee.
Yes, yeah, thank you.
And I'm not bothering you at all.
She is not. This is, so I just want to be the intended, the way that I just want clarification on how the 1.5% assessment works, is that money would come out of the general fund. Okay. All right. And then we would do and then you're also proposing the $5 going to $5. I think, yeah, I think I'll say a couple things. I certainly am concerned with the assessment. However, I do agree with everything that's been said, that the idea behind this has been to try and get more pass-through funding and try to help with lowering premiums. And that particularly when this first started, it was very effective. And I do think part of what was said by the Bureau and what has been said is that the ability to deliver it is really based on the ability that they can get revenue from this assessment. So I am certainly in favor of this. I do think, though, that as has been said as well, we do have to look at other potential structural changes going forward. But right now, I recognize it's very tough with the time crunches that we're under and everything like that. But I do hope that as future sessions, as we, with the Bureau, they'll continue working, getting us information, as well as the carriers, on looking at structural changes to the program. As far as, again, the original intent of this bill was to do away with the pooled market. I recognize that's not going to happen, but I do think that study, continuing to look at the pooled market, is something that we need to do as a committee and as a legislature. Is that really the most effective way to go forward with this, is a continued pooled market, as well as taking a look at other issues within healthcare. Obviously, there's stuff from Washington going on right now that's not giving us any help too. I fully recognize that. So I certainly will support this proposal, but I just want to say going forward, I do appreciate the committee's concern and everyone's willingness to work on this together, and I hope we can continue in future sessions to continue to work on this program to lower people's healthcare costs, because that, I think, is what the overall of what we're trying to get at with any proposal. So thank you.
Representative Matheson.
Thank you, Representative Morris. I would just ask when we do get information back that if we can get a calculation on what this increase would do for decreasing premiums in that information, that would be really helpful.
Further discussion.
I have a question before you go. I
Yes.
need some clarification on the second part of the proposal. I understand increasing the assessment to $5 PM per member per month. The 1.5 premium assessment, is that you want just a transfer from the general fund of the equivalent of what that would be? Equivalent amount of money. So nobody's paying a new assessment. Are you suggesting that it come out of the premium taxes that are already paid and you take a portion of that and transfer it out that are already going to the general fund, or just a new general fund appropriation equivalent to that 1.5, what a 1.5 assessment would be?
The latter is what I understand.
Just a transfer from the general fund of, figure out what a 1.5 premium assessment would be equivalent of, the total dollars of that, and then you would want a general fund appropriation of that amount.
Right.
Thank you. That's what I thought, but I just wanted to make sure 'cause when I draft this and figure.
Thank you,
I
because
need
that's
that.
what I understood too, so. Glad we were all on the same page.
Nobody's paying any new assessment of 1.5.
Correct. Just using that
Just
though
using it.
as a way to come up with the amount. Yes.
Thank you.
Okay, further discussion? Did you have? Yeah, okay. All right, I think we're ready in the.
Thank you. Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
Yes.
Representative Alford, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Shabino?
Yes.
Representative Shabino, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 10 members of the committee having voted in the affirmative and 0 in the negative.
All right, so that motion passes. And, but Representative Foley, before you leave, I did want to say that the difference between you and I is that, you know, when there was a snowstorm, you were crunching these numbers and doing insurance. I was making cowboy chili. All right. Wasn't me. All right. And we will open the work session on LD 1901, an act to regulate shared appreciation agreements relating to residential property. And
So-
I know there were some
Yeah.
more discussions.
Mhm.
And that there may be an agreement how to move forward.
Oh, really?
We-
Oh,
or
I don't
we-
know. I didn't hear that, but
Okay.
maybe I'm not getting the most information, but
Okay.
what Edna's handing out is sort of the last version of an amendment that was suggested by the Bureau of Consumer Credit Protection based on the meetings that the interested parties have been having. Although this does not represent the consensus of the parties as I understand it. This proposal would regulate shared appreciation agreements under the Consumer Credit Code and treat them as credit and subject to many of the provisions of the existing Consumer Credit Code, and then also require some additional requirements that the committee has worked through. My understanding, based on the 2 phone calls that I participated in with the interested parties, although admittedly I was coming in very late to the party, that there still is significant disagreement on one particular provision that prevents the parties from reaching consensus, which is the provision related to assignee liability. Which if you're looking at that or want to find that in the draft, it's on page, I page numbered it for you. It would be on page 7, paragraph J. So that's where, as I understand it, where the most significant kind of disagreement or sort of philosophical parting of the ways is occurring between the parties. I think it's a deal breaker on both sides, as I guess I would characterize it. So they haven't been able to reach consensus. I know the committee had asked at the end of the work session, at the last work session, to have some changes to that provision. Representative Olson had suggested taking out the word nonprofit with regard to counseling. That change has been adopted in this draft here. And then also, Senator Bailey, you had suggested including some language modeled on the improvident transfer statute, which has also been incorporated in this draft on page 9. So you'll see those changes were made based on the committee's feedback. I know representatives of the parties are here, both in person and online. If you have some additional questions, the committee had also talked at the last work session about additional options, putting forward legislation that would ban shared appreciation agreements. So there has been some language, I think, that may have been shared with committee members electronically to do that. I know the committee talked last time about a moratorium for a certain period of time and then continuing to talk. The committee also talked about leaving in place the advisory ruling that the Bureau of Consumer Credit Protection has put in place at the end of the last session of the legislature. So unfortunately, I don't think there's a consensus of all the parties. And I think because of the sort of significant disagreement on the assignee liability piece, my understanding from the last meeting was they didn't think that they would be able to bridge that gap with that provision in there. Although I think they, had made a significant effort and, had many meetings to talk about different alternatives and shared language and had stakeholder meetings. So I'll leave it at that. And as I said, if you want to hear directly from the parties, you have representatives here in person and online from both sides, both representing consumers and the industry and the regulators.
Thank you. And first of all, let me just say, I do thank all the parties because I know that they have worked really hard and had many meetings and discussions. And I think everyone has been trying to operate in good faith. So I just want to express my appreciation for that. My understanding is the request from most, if not all of the parties, was to put a moratorium in place for 3 years to allow everyone to kind of continue their discussions, allow us as legislators to kind of see how these play out in other states that have allowed them. But I'm certainly open to being corrected on that impression if that is not the consensus of the interested parties. So if anyone on the committee has heard anything else, or if anyone wants to call up anyone, Representative Foley.
I would agree with you, Madam Chair. I think a moratorium, it is helpful when you have groups that are diverse and they work to come to commonality. And I think they're working towards that, but not quite there yet. It would be my feeling that we would leave the advisory ruling in place and then put the moratorium on for 3 years and see how this whole industry works in other states and see how much more room they can do to come together would be my thoughts.
Okay. Further discussion? Does anyone want to hear from anyone? Does anyone who's been involved in this feel compelled to come up because, again, this is your chance to correct me if my impression is wrong in terms of the moratorium. Mr. Cox.
Thank you, Madam Chair, members of the committee. My name is Thomas Cox. I'm from Yarmouth, Maine. I'm 81 years old and I thought I retired a couple of years ago, but here I am. I began representing homeowners pro bono back when the financial crisis began, 2008. I've represented hundreds, maybe over 1,000 homeowners in the foreclosure cases over the years. The S&E liability is an experience we suffered after 2008. The subprime mortgages were sold into the secondary market in such a way that when I tried to defend a homeowner, I was unable to assert a claim that there had been a fraudulent inducement by a subprime lender to suck that homeowner into those loans. It's been a disaster for homeowners and an inability to defend those cases. S&E liability issue is a critical issue. And it's not going to change 3 years from now. We have worked real hard for the last since May. And this industry's been around for about 7 or 8 years now, so it's not a totally new industry. So I think we've worked hard. I think the big bill, I call it, is a good bill. I think it still allows these loans to be made, but it puts decent guardrails on them. We work closely with the Bureau of Consumer Credit Protection. I believe the Bureau is willing to support that bill. They're willing to go with a moratorium too, if that's the wish. But I believe the Bureau also think that is a fair bill. So I think we ought to go in that direction. As a further compromise to clarify Representative Foley's proposal, you do have, or at least some of you have, a draft amendment that would simply ban these products. If you're inclined to go with the moratorium, I recommend you take that amendment and then attach a sunset clause on it. You already have most of the language you need for that. Thank you.
Okay, if you could just hold on, make sure there are no questions. You know that. Any questions from committee members? All right, seeing none. Thank you for your input. Thank you for working on this working group, I guess we'd call it. So, does anyone want to hear from anyone else? Right, so what is the will of the committee? And yeah, Colleen, if you could kind of clarify it, I mean, is there a difference in when we say a moratorium for 3 years versus we ban these with a sunset of 3 years?
Well, I think there's potentially a difference between what Representative Foley was suggesting and what Mr. Cox was suggesting. And I think those are your options. So you could ban them for 3 years, ban them and then put a sunset on 3 years, which is effectively a 3-year moratorium.
Right.
The other option that I thought I heard Representative Foley say was have a moratorium for 3 years, but leave the advisory ruling in place. And I think that would be a little different. That might look like you can issue these if they can, meet the standards of the advisory ruling for 3 years. Do you understand what I mean? Like, the agreements are, shared appreciation agreements are okay if they meet, whatever the standards of the ruling, so I think those are two different things, perhaps. Because the advisory ruling, as I understand it, says these agreements are mortgages and will be regulated like mortgages.
Yeah.
So that seems to me, if you're going to leave that in place, the moratorium that stays in place for 3 years, meaning if you want to do business in Maine and issue a shared appreciation agreement, it's subject to the advisory ruling. So I think those are two different options for the committee to consider when you talk about a moratorium. And those are policy decisions, I guess.
So one is really a moratorium, a ban with a sunset in 3 years. The other is status quo for 3 years.
Which is kind of a moratorium, on what you, right?
Okay.
On more regulation, I guess.
Sure. Linda Conti, if you could come up. Yep. Representative Strong.
Colleen, do you think, and maybe Linda can answer this, but what's the downside to saying that there's a moratorium with the advisory ruling in place. I'm just trying to figure out why wouldn't we want to?
Well, I guess the question would be, do you want consumers to be able to access the product for 3 years or not? And if you were willing to allow them to access a product that meets the standards of the advisory ruling, then you'd go with that option. If you didn't want this product to be available in Maine, you'd go with the second option, which would ban it for 3 years.
But if we ban it, we could end up in court. I'm just trying to figure out the way
I
to
don't
do
know.
this so that they don't want to,
Industry
so
might
they
have
don't
to-
want to do business in Maine.
Industry would have to probably say whether or not they would take
Challenge.
legal action, but.
Challenge it, right?
Yeah.
All right, Ms. Conti. Oh, welcome. You want to ask me a question or you want to hear from me? I support the latest draft that you have of the bill. And I just wanted to say one thing about the assignee liability. There were a bunch of those similar provisions, assignee liability of one of them, that apply to all high-cost mortgages in Maine now. So and these are high-cost mortgages. So the Maine high-cost mortgage rules would apply to them. And we were unwilling to carve them out, to carve out an exception from them, from the high-cost mortgage rules. So that's where we sort of came to this impasse. It wasn't like we were imposing a requirement on them that didn't already exist. It was like we were saying, no, we can't take you out and not take everybody else out. You know, that's something for the legislature to do. So I just want to say that. And the industry has worked with us. We've had many, many robust discussions about the math of these products. And Ed with his calculator and that they with their calculators have gone at it for hours and they haven't really come up with agreement on how much we can limit. I wanted to say, okay, we can allow it, but we got to limit how much they can charge for these. We got to limit how much money they can take from consumers. We got to keep it small. And we never were able to really hammer that out, but we're still working on it. So I just don't want them to be able to come in and get around the high cost mortgage provisions. And I'm not 100% sure advisory ruling 122 takes care of that issue. But I would support a lawful, I mean, the industry has come to me today and said, would you support us sort of going away for 3 years? And I said, well, I support the bill 100%. I would not object to them going away for 3 years if it can be done in a way that's enforceable, right? Like you're really going away. And I don't, that's
the question.
that's what Colleen's struggling with. And that's what I say is for her to draft and not me.
Which again is,
Right.
we're saying a ban with a
Right. But
sunset in
I
3
would
years.
also like to go off topic here and say, I sent a link to Colleen earlier today.
I haven't had a chance.
You haven't
share
had a
it yet.
chance to look
No.
at it? Well, did you
Questions
look
from
at
home.
it?
I did.
Yes. So Ed and I were called by a TV station in Boston who wanted to do a story on our kiosk law. And it is great and it really features you a lot. So I really want you, because this reporter is like, well, what's the Massachusetts legislature doing? Maybe they should look at what Maine is doing. And, you know, so there is really good stuff about being a leader and having other states look to us and some of the things that we're willing to take on and do. I mean,
There's a reason we left them in 1820.
so having said that, you know, the Sarah here, I don't know if she do you want to talk? I mean, I don't want to take all your air, but the industry did come to me with a proposal and I'm not going to sit here and object to it. It seems like a decent outcome, but it's a nice, strong bill too.
Okay. Representative Matheson.
Thank you.
Thank you very much.
Yeah.
So I guess my question is, if we pass this bill as is, with that, I understand where the stakeholders land on this, and I understand that there's no common ground there. But I feel like if we pass this, it would effectively ban them because they wouldn't come in and do business with us. Is that correct?
They say they won't, and maybe some of them won't, but maybe others will evolve a new product that works around that. I mean, and
some of the, what I'm faced with a little bit with this product, which we think is a mortgage, and they're coming in here and saying, no, 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 this isn't a mortgage, it's an investment. And some of the other products that people are coming in and trying to say, this is not what it looks like, it's something else. I think it really is what it looks like. I mean, so I think our existing laws that are on the books that are going to make it difficult for them to do business here, I don't see a reason to throw out those laws at this point in the process to see how that would shake out.
So just if we were to do a moratorium for 3 years, what does that do with all the work that was put into this?
Well, I don't think the work will go away. I think we'll all be, willing to continue to work on it. And like they said, get information from other states where they are operating, see how it goes. I mean, there is always the opportunity for further discussion and further drafting that's not under such a deadline.
Thank you.
Yeah.
Further questions? Representative Boyer.
Thank you, Madam Chair. Thank you, Linda, for being here. So can you just go back for me to say, if we do the moratorium and we leave, what was your concern with doing the moratorium and leaving just the advisory ruling? You felt like there was potentially ways around the advisory ruling, maybe?
Yes, and I'm not sure what they are, but Ed thinks that.
Okay.
Well, it's not statutory.
Yeah,
It's advisory, so that's.
That's true.
That's the
Okay.
big-
Yeah.
That would be the
That's
big
one
thing.
big thing, yes.
So you could codify in some way the advisory ruling,
Right.
Yeah.
put it in place for 3 years, but that's it's almost
I mean,
like a ban.
I think if we were gonna put anything in statute,
Yeah.
it would be inclined to.
That's the-
Speaking for
that's the
myself, if
policy
I was gonna
question.
put anything in statute, I'd be inclined
Yeah,
to
me
put this proposed bill in statute. So it's really, for me, it's a question between passing this or putting a 3-year moratorium in place. It's,
I mean, you could
Right.
pass that with 3-year sunset too.
well, you could do that too.
That's, well, that's some sticky questions. for
Representative
you.
Chino.
Thank you, Madam Chair. So I just have a question. So if it's a 3-year with a sunset, that means after the 3 years, it's done.
It would be
Correct.
repealed unless the legislature takes action to reenact it or remove the repeal provision.
So, but we could readdress it then after that,
Yeah,
see
it
what
sort of
other states
forces
have
the
done,
legislature
see
to
what
come
other
back to it.
courts have done.
Yes.
And during that time, they would not be able to practice here because it's a moratorium.
Correct. Well, they would be able to practice here. They're just saying that they can't make their product work or they can't make money with their product if certain laws apply to them, so they won't want to come here. So what they can do and what they want to do or are willing to do is never really, really clear to me. They're saying if you make these high cost mortgage provisions apply to us, we're not coming to Maine. And, that's kind of their choice. I mean, whether or not they could come up with a product that could comply with that, I don't know.
Representative Chino.
Thank you. So let's say they say, well, we're not going to come here. All right. But then a year goes by and they decide that they are going to come here. What law do we have in place to protect consumers during that time?
Well, if you didn't do a moratorium,
If we have the moratorium in place and it's got the sunset on it for 3 years. And during that time, they, first they say no, but then they decide they want to go ahead and give it a try. What recourse does the state have?
so if they violate the moratorium, then I had evidence of that. Like I found someone called up and they had one of these loans and I said, hey, this loan's illegal in Maine. And they're unlicensed by me. I'm going to call up my assistant AG that represents me and say, this is a case I would like to bring. So we would be able to enforce the moratorium. Similarly, you really can't bind a future legislature. And now I'm kind of getting into Colleen's territory, but anybody can always come back with a new bill. So in January of 2027, somebody could come back and say, that moratorium you did, we think you should lift it now. And these are the reasons why we think you should lift. So as the legislature, you can always, and entertain a new bill to do something to an existing statute.
And that goes back to that none of this will be wasted, if
Right,
something
yeah.
like that happened, right?
Yeah,
You know,
right.
Because the legislature would just be looking at it again. So,
Right.
okay, further questions for Ms. Conti? Yeah, I did see a hand up in the back, and I feel like since I said, all right, go ahead.
So if we did this,
Mm-hmm.
would this make it really difficult for them to do business in Maine?
That's what they say, yeah.
Okay, then I'm gonna just weigh in that rather than a moratorium what leaves a lot open, I'm gonna say that right up front that I'm gonna support this.
Any other questions? All right, thank you.
Thank you.
Since we heard from Mr. Cox and Ms. Conti, I feel like I should give the industry a chance. I think I saw a hand there, just to hear from all sides.
Hi, Sarah Vanderwood from Main Street Solutions, resident of Oxford, and I'm here on behalf of the Home Equity Partnership, Coalition for Home Equity Partnership. You have heard from my client previously. We are supportive of a moratorium. When we came before you last year for the public hearing, we told you that we would not operate in the state of Maine until this issue was resolved in some way. I think we continue to believe that. We do think a moratorium is a good place for the committee to go. It gives the market a chance to mature in other areas, gives you experience in other areas and other jurisdictions. I do have my client Lee Kaplan online who has appeared before you before. I do think if you would indulge him, he does have a few things he'd like to say.
I'm not quite sure what he's going to add that you can't answer for us.
Okay. If they're technical questions, I would like to defer to him.
Okay. Yes, absolutely. Questions from committee members? I think
Okay,
we're all
thank
set.
you. Thank
but
you.
Thank you. All right, so further discussion. Like I said, we have to vote these out before the end of the month, so we kind of have to make a decision here one way or another. No, we do not have a pending motion. Representative Chimino.
Yeah, I support the moratorium. I think it gives us, we're still protected legally should they decide to come in during that time. I think it also gives us a chance to, make better, possibly there will be some reconciliation as far as liability. Even if there isn't, maybe there's going to be a tweaking of that product, but at least we'll be able to hear what other states have to say. There are going to be court cases throughout the country where these are operating. And I think it just gives us a chance to sit back and reassess, but it doesn't close the issue. So I would
So
be
was
for the
that a
moratorium.
motion?
So it's a motion for the moratorium for the 3, yes, for the 3 years.
All right, thank you. Is there a second? Seconded by Representative Morris. Further discussion, Representative Matheson.
My only concern about this motion is that it will go to the courts. So what happens then? What if someone takes us to the courts? Do we not have this statute on record, right? Then we go back to the advisory. I don't want this
It
to.
depends on what the motion for the moratorium is and how you wanted to do it. Like we just talked about it.
Yeah.
Is it just gonna say, is it gonna? Yeah, I guess it's the same thing. I guess it's effectively a ban for 3 years is how you would do it. So, the question is, would somebody come in and ban it as a violation of, their right to do business in Maine?
No, yeah, I guess I'm just curious.
And then the court could say, yes, it is, and issue a declaratory judgment, and then the law would be unenforceable. I mean,
Yeah.
potentially that could happen. Or the court could rule in favor of the legislation and say, this is appropriate action, and it stays in place. It's just hard to predict.
And I think a ban with a sunset in 3 years or passing this, either of them are subject to challenge in the courts. If any industry wanted to pursue that. So for me, that's not a factor.
Okay.
In making
appreciate that.
in making my decision, because they can always
Always
challenge.
challenge.
Yes, absolutely. And not saying they're going to, but
Right.
they can, Representative Foley.
Thank you, Madam Chair. You know, what would your thoughts be on if we pass this and put a sunset on it in 3 years? Then we have this on the books. We have a statute on books, but we sunset it in 3 years. Because essentially you've got the law. Would that work?
I mean, you can do that.
I mean, just as an alternative to, I'm just trying to think that might give us a little, I know we're not supposed to think about it, but a little better legal protection that we did pass something and we're gonna put a time limit on it. I don't know, just, I'm trying to think how we can have more protections during this period of time. I'm just not sure the moratorium per se is the best route to go, but I guess we can keep talking.
Yep, Representative Mastracchio.
Thank you, Madam Chair. You know, that's an interesting idea from Representative Foley, because my experience with things with sunsets that are somebody will come back and either want to extend it or repeal it or just let it die out. And I do think I would really like to hear that, because that sounds to me like we've got something really concrete in statute. We'll know if it works. And then if they have a product and they want to come back and argue why we shouldn't extend the statute and not let it sunset out, they'd have to come before the committee, whatever committee is here at the time. So I don't know how everybody else feels about it, but I do think it addresses my concerns about not having anything really in statute other than a moratorium.
I mean, it's an interesting concept because what you're essentially doing is you are putting a ban in place for 3 years. I mean, according to the industry, this is effectively, operates like a ban because they're not going to operate. So it's kind of an indirect ban. So it interesting. I'm pondering, Representative Olds.
I think if we kind of went with our usual, a somewhat usual hybrid approach, was to pass this with a sunset, but with a letter.
There we go.
With a letter directing Ms. Conti
And welcome to our committee, Representative Olson.
to come up with effective rules behind it.
I'm sorry. I wasn't listening. I was being flippant. So the letter would be what?
The letter would be for the department to draft rules specific to these type agreements.
I think that's what this is, though.
Yeah,
I mean, they've already started the work there.
Yeah.
With their advisory,
Yeah,
that would direct them to
this
be able
would be
to.
their instructions, would be this. But
I would say one thing that has been done before, when the committee has put a sunset on something, is there's been a directive or an unallocated language to the agency that's responsible for administering it, come back to the committee with a recommendation on whether or not it should stay in statute or not, based on their experience. So that might be, you could add a provision that, a report back, you would set the repeal date. If you're thinking of, my experience also with repeal dates is you don't want to repeal it on January 1st because the legislature doesn't have an opportunity to act. You want to put the date in a time where the legislature will have an opportunity to act. So say 3 years from now during the second session, I think is more helpful than the first, because the committee has experience and will kind of know what a repeal is and all that sort of stuff. So you could have a report, in February or March of 2029. And the repeal date could be some April 1st or something like that. So then the legislature would have an opportunity to act. I think the issue sometimes with the January 1 repeal date, it kind of forces a decision well in advance in order to allow the legislature to take action. So I guess I would recommend having the repeal be sometime during a second session, because I think there's more opportunity for a legislature or the committee to flush that out and make that policy decision about whether it should be extended or the repeal should be allowed to go into effect, or, you know, put the legislation in that allows them to do that. So if you did that with a report back from the agency, say, then you could also give the committee authority to report out a bill to deal with the sunset.
All right, Representative Boyer.
Thank you, Madam Chair. My arm was about to fall off.
Sorry.
I think I'm inclined to support the moratorium. I think a concern I have with if we enact it and put a sunset on it, what does that do to Linda and Ed? Like, how much work do they have to do to try and implement what's in here from the back end for us to then sunset it in 3 years potentially? I think that's just sort of where I'm thinking, and maybe it's no work for them, but it seems like this would be, you know, something they're going to have to implement. And then if we sunset it in 3 years, I think I'm more inclined for the moratorium.
So would you like to ask Linda that question?
Sure, Linda, do you want to come back up?
I don't think I can answer that question.
Let me just say one more.
Yeah, Representative Matheson.
I definitely want to talk a little more about the dates if we do this sunset, because I ran up against a repeal of a sunset before a bill could get passed because it wasn't an emergency bill. So I just want to flush that out. Yeah, thanks.
Okay.
Do you want me to ask my question again? Okay.
You want to know how much work it will be?
Yeah.
Well, for one
so
thing, I owe you a letter and it's on my desk. As soon as this is over, I'm going to finalize it and get it to you. So on the letter writing piece of it, I'm used to that. But the report that's our job. You know, I am perfectly happy to, if you put it on a sunset with us to sort of report back. I mean, we watch what's going on in other states and they watch what's going on with us. So I don't really think that it's gonna.
Implementing the bill, though, if it's already.
Implementing the bill.
Would that be a lot of work, and then say the legislature repeals it in 3 years? I think that's what you said.
No, because, well,
hold on, she's
it would be some work, because we would have to have a licensing. If someone came forward and said, we want a license, they would be getting they'd be getting a mortgage license, and we're already set up on NMLS to take license applications. You know, I don't think it would be out of the norm for us. Yeah.
Awesome. Thank you, Linda.
And we've already done so much work.
Yes. Yes.
On this, that it will be easy, and we have a lot of people we can talk to about it.
And Ed is an expert. Oh, Linda. Don't go away yet. Representative Foley.
So within this bill, you have rulemaking authority.
Correct.
So you can, and they're not major substantive, I don't think.
No.
No. So routine technical rules, you have the authority to make up.
Whatever she needs.
Right,
to do.
exactly. To have a public hearing, just like this, and have people comment, people have the opportunity to comment on them, so.
Okay. Any other questions? All right, thank you.
Thank you.
Oh, Representative Camino.
Thank you. So then if we went with this and then and then we had a sunset on it, at the end of it, of the 3 years, when the sunset expires, then this is then the law?
No, then it goes
No.
away.
Then it goes away
The opposite.
completely,
It
and
goes
then we're
away.
back to
Right.
square one with it.
Unless the legislature reenacts it or changes it or does something in some way.
Yeah.
So one of two things could happen. One, it will be extremely unpopular and we'll never hear about it again. Or two, it will be extremely popular and there'll be all kinds of new bills that will come in asking you to do something different. But it would be up to the legislature in 3 years whether they were going to let it go, reenact it, or do a third thing.
Amend it.
Yeah.
Yes. Okay. I want to just make sure there were no more questions from Ms. Conti. All right. I think
Thank
we're all
you.
set. Thank you. There is a pending motion, Representative Mastracchio. It is the motion for a 3-year moratorium. Which I don't know, Representative Chimino, if you want to withdraw that or if you're still inclined. But that is the pending motion.
Yes, Josh?
I was gonna say, maybe we should have a corner.
That's a good idea.
That we can absolutely do. All right, so let's take like 5 minutes. Welcome back. Thank you for your patience as we took some corner caucuses, had further discussions. I think we still do have a motion on the floor, right? And so there is a motion on the floor for a 3-year moratorium, correct? Okay. Further discussion. All right, I think we're ready.
Thank you. Senator Bailey?
No.
Senator Bailey? No. Representative Matheson?
No.
Representative Matheson? No. Representative Boyer?
Yes.
Representative Boyer? Yes. Representative Shabino?
Yes.
Representative Shabino? Yes. Representative Flynn?
Yes.
Representative Flynn? Yes. Representative Foley?
Yes.
Representative Foley? Yes. Representative Mastracchio?
No.
Representative Mastracchio? No. Representative Olson?
Yes.
Representative Olson? Yes.
And so, but, go ahead.
No. Then what's your motion?
Yeah, so calling on the minority report.
Yeah.
We would want the Foley amendment, but we need to talk about the dates. What did you want to see for dates?
So it's the salmon with the 3-year sunset.
Yep, and the unallocated language.
Yep.
With the report back.
I guess I just want to make sure that there's time in that second session that that we don't see the sunset repeal the law before a bill can come forward and either keep it or change it, which is what I experienced before, was that because it was 90 days after adjournment, that any
What
change.
was 90 days after adjournment?
The-
The repeal
when-
date or the date when the new bill went into
The
effect?
date when
It
the new
wasn't a-
bill.
Yeah,
Yeah.
yeah.
So I don't know how
That's
to,
the danger, yeah.
I don't know how
So-
to do that.
Yep. So I think you want to report back during the second session. So you're still thinking 3 years. So would we be a report back in 2029? Say,
I'm just thinking, would the report back, can the report back come early
Yep.
in January, but then the repeal would be
Yeah.
at the end of, closer to the end of the session, so it gives the legislature, whoever is here,
well, absolutely.
some time to
enact it.
to
but
enact an emergency if
It
they
would
need
have to be
to.
enacted as an emergency, but
Yeah.
I thought you were saying push it back sometime into like September or October, so you could
Yeah.
enact a bill to extend it without an emergency, which you
Yeah.
could
I
do.
think that's probably our
Which
best
you
bet.
could do as
Yeah.
well.
Yes.
Yeah.
Yep.
Yeah.
So, okay, so you could do. You report back in 2029 and you repeal it on January 1 of 2030.
Yep.
Yeah.
I mean, just to be clean of your repeal date, but then you would have to take action during the second session.
Thank you.
Okay,
So everyone else.
does that make sense?
Agree.
Okay, so the 3 of you are on that report.
Yes.
Okay. So a report back in mid-January of 2029, repeal date of 1/1/2030, and then the legislature would be able to act. Okay. Thank you. And then on the moratorium, you're comfortable with a draft that bans them for 3 years? The amendment would ban these agreements in Maine for 3 years?
Correct.
And with the 3 years, okay.
Okay. And I know we had some other members join, but you can probably vote afterwards. Okay.
Yeah.
Cool. Yeah.
And if you have questions on what, what's what, like.
The 2 different reports. Ask Colleen or
Or the committee.
ask any of us. Yeah. All right. So we will close the work session at LD 1901. Thank you. And open the work session on LD 1915 and act to regulate earned wage access services providers.
So this is another bill that the stakeholders, I understand, have been working hard to try to come up with a proposal that reflects the consensus of the parties with the Bureau of Consumer Credit Protection. My understanding is that they have been meeting, would like to continue to meet, but haven't reached consensus. You have representatives of the industry and Superintendent Conti are here. I would also note that Representative Skold, who is the sponsor of the legislation, has submitted a letter to the committee that I think Edna distributed to you, asking that more time be given to the parties to continue to work on this issue. He would ask the committee vote the bill ought not to pass at this time. I also believe that there are some existing memorandums of understanding that have been entered into by several members of the industry and the superintendent of Consumer Credit Protection. And so the committee could take some action with regard to those if they wanted to communicate how that would be handled. If you're inclined to take Representative School's suggestion. So I'll stop there, but I know folks are here and can update you on their discussions.
Okay. And I think that Ms. Conti and we're gonna present together. I don't know if we have an extra chair somewhere. Okay.
I'm not getting into the smaller bits.
Okay.
Come on. I'd sink right down.
This is just representative that the superintendent lords over us.
High chair.
Senator Bailey, Representative Matheson, member of the committee. I'm Charlie Sullivan. I represent Daily Pay and have worked with the industry, and I'll let Linda introduce herself again.
I'm Linda Conti, Superintendent of the Bureau of Consumer Credit Protection.
Okay, and so
We have been working tirelessly. I want to thank you as chairs and as members to give us time to do so. And to Linda and Ed for his efforts. It's a complex issue. And we have agreed to a lot, but not everything. And we'd like to continue. And as a result, we have, I think, agreed that kill the bill. We have the MOUs in place. We will behave, obviously, under those MOUs. We have the guidance. And we will continue to work in good faith with the superintendent and her staff to work through what is really a difficult placement into either Title 32 or Title 9A. And so on. So that's, I think, what we would like you to do.
okay, Ms. Conti, are you in agreement with that?
I'm definitely in agreement that you vote this bill ought not to pass.
And we still have the advisory ruling will still be in place, plus the MOUs.
There is an advisory ruling in place, and I have entered into MOUs with several, but not all of the earned wage access companies in the country. And those MOUs are up to my discretion. I could cancel them. I can keep them going. Right now, the way it's working is they are providing in exchange for me having this MOU that, I'm not going to go after you. They're giving me information about what they're doing for business in Maine. This is one that came in today. So the people are telling me, their gross revenue, the total number of transactions, the names of the companies that they are working for the employers, and the total dollar amount of earned wage transactions that they've done. And from that, we can Ed likes to calculate what the APR would be, and it would be, for this particular company, would be 136%. So we're gathering information. We're happy to keep gathering information, and hopefully we'll have this synthesize this information, and we'll all come back to you, hopefully with something that we agree on. Next session, right? You put in a new bill?
Glad to.
Or I'll put in a bill, or we'll both put in
We will
bills.
do it hand in hand.
All right.
All right, questions, Representative Olson.
No question, but I'll move the ought not to pass.
Second.
All right. Any other questions for Mr. Sultan or Ms. Conti?
Yeah, thank you.
Thank you.
Appreciate it. Thank you.
So were you going to call me?
Yeah.
All right, further discussion. The motion is ought not to pass. Seeing none, Edna?
Thank you. Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Arford?
Yes.
Representative Arford, yes. Representative Boyer,
Yes.
Representative Boyer, yes. Representative Shabino,
Yes.
Representative Shabino, yes. Representative Flynn,
Yes.
Representative Flynn, yes. Representative Foley,
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Morris,
Yes.
Representative Morris, yes. Representative Olson,
Yes.
Representative Olson, yes. 10 members of the committee have voted in the affirmative and 0 in the negative.
All right, thank you. And that'll close the work session on LD 1915. We'll open the work session on LD 1890 and act to facilitate the development of ambulatory surgical facilities by exempting certain facilities from the requirement to obtain a certificate of need. This is one that we've already had one work session on.
Yes.
And I think that we, at the last work session, I recall at least one request for information from the department.
Yes.
A question to answer.
I think that's right. I think
Okay.
the committee had talked about possibly amending the proposal from Representative Foley that was presented at the public hearing even further to increase the threshold levels, but wanted to give the department some time to evaluate the proposal that had been talked about. So increasing, I think, the 5 million to 7.5 million, and then gradually increasing, as I understood it, up to 10 million. And I believe Mr. Monteo can provide you their feedback after analyzing the impact of that.
Okay, thank you. Welcome.
Thank you, Senator Bailey, Representative Matheson, members of the committee. I want to thank you for giving us the time to look at this. We went back, Mr. Lawrence and I, and did a review consistent with what we previously provided you, which was a 5-year look back of the ambulatory surgical centers. We went back and looked over the last 5 years of all non-hospital, non-nursing home, CON healthcare projects that were subject to or were submitted for letters of intent and review. And what we found was that the proposed increases, although they would not have changed any of the outcomes as to what was and was not reviewable, making such a change is not without risk, and the department is opposed to increasing it beyond the 5 million. Allow me to explain. When you increase the thresholds beyond 5 million, you increase the risks of projects from a complex investor equity type of situations that would not be subject to review. And you create a risk that not only the department, but the state cannot review the impact on not only main care, but more importantly, on the payer mix within the community and on the existing facilities. When we, as I stated, when we went back and looked, we saw that increasing it would not have changed the outcomes of what was and was not reviewable. And I want to give you a scenario that was a $8 million project, but was not subject to CON review. And this is kind of highlighting why we're concerned about some of the risks. The project was an existing ASC that was going to build a replacement facility and relocate into a neighboring community, increase its capacity from 2 surgical beds to 4 surgical units. But the way they did it was not consistent with kind of the tradition of buy property, buy a building, construct. It was a lease arrangement in an existing medical practice facility. So, and because the arrangement of the entity had already determined need because it was an existing provider, the needs analysis was removed from the equation. But the lease arrangement, and this is something new that we're seeing more of, allowed for the renovation of just the space occupied by the ASC within a larger medical complex building and dropped it below the existing threshold of 5 million. So it's not prohibiting more development and increased capacity, but such arrangements, if used in other situations, could result in larger projects, $8 to $10 million projects in new settings where a building was purchased or acquired through a bankruptcy process or a lease arrangement such as this, to exclude all of that cost of construction and renovation out of the mix. And so the concern from the department is that by not allowing the department to review these, you're taking out our review and analysis of the payer mix in the community, how it impacts. And an example of that is If you had a small community access hospital that was in an area of Maine that was 60 to 70% Medicaid as a payer mix, and you brought in a ambulatory surgical center that was going to do commercial insurance and private pay only, the CON analysis allows for the department to look at that payer mix and can pose a condition, for example, of requiring the new ASC to have a comparable payer mix, to have an equitable situation, so you're not shifting the low reimbursed patients all to one provider and the higher reimbursement patients to another. That's part of the concern of this type of an arrangement. The department is comfortable. I shouldn't say comfortable. We are agreeable to the $5 million with the CPI index, but increasing it beyond that with what we're seeing in trends is concerning, and we do not support that. So we would be opposed to that increase of 7.5 and 10 million. I will share with you that what we have seen, and this is information that's on our website, is in the past 5 years, we've seen 6 commercial urgent care facilities that have opened up and operated in the state of Maine, all not subject to CON review because they've been under the threshold that currently exists. We've seen 2 commercial outpatient radiology facilities that provide X-ray, CT, and MRI services, both located within a couple of miles of existing hospitals. We've seen 2 hemodialysis facilities, one a 12-bed and one a 15-bed capacity that were opened up and not subject to CON review. And we've seen 1 outpatient targeted radiology treatment center that was opened up that, again, was not subject to CON review. So we're seeing healthcare projects that are coming into Maine that are not subject to CON review and under thresholds. I provided you data previously that showed the ASCs. A lot of the smaller ASCs are really focused on dental ambulatory surgical or ophthalmic ambulatory surgical facilities, but we've also seen renovations and expansions of existing ones that are still coming in under CON thresholds because of this change in how they're financing and processing.
Questions, lots of questions. Representative Boyer.
Thank you, Madam Chair. Thank you for being here, Mr. Montiel. I think, at least for me, some of the hope with raising the CON threshold is that we might have more come into the market. Of those that you listed, the 6 and the 2 and the 2, are these new players in the market? Are these existing companies that are here that are expanding? Because I think what I've seen is it was pretty much people that are already here in Maine, companies already here in Maine that were adding maybe an ASC or something like that.
Yeah, these are, the ASCs that I provided you previously, some of them were new ambulatory surgical centers that were specific to dental practice or ophthalmology. The list that I just read you of the urgent care facilities and the outpatient radiology practices are, one was an existing company that I'm aware had existed prior to the 5-year look back. Many of the others are new. They're companies that may exist in Maine, but they're new locations and new facilities that were built.
But they're existing entities in the CON system.
Not definitively answer that because I did not go and look at the ownership and if they existed prior to. We simply went back and did a 5-year look back of what are the projects that we've done in the last 5 years. One of the radiology practices I know because it existed prior to 5 years ago in the community in which I live.
Okay. Can I ask a follow-up question? And then regarding payer mix, I thought when we had talked about certificate of need before, payer mix is not a reason for denial of a certificate of need.
It's not in and of itself, but it is a consideration when you look at the payer mix and the projected revenue that the applicant is projecting. The CON does look at what is the payer mix in the community. And if you've got a large Medicaid payer mix and a provider moving in that is only going to take private pay and commercial insurance, and you have existing healthcare entities that are doing Medicaid services and commercial and private pay, there is an analysis, and that's part of the impact of on the main care system of would this result in a shift of the mix currently in the current healthcare provider of all the private pay and commercial insurance to this other provider, that would have a negative impact on the existing provider. It's kind of that old adage of penny wise, dollar foolish. Are we shifting the burden to one existing provider to take all the low cost and therefore lack the payer mix to compensate? And we've seen this in the nursing home industry, quite frankly, where there's a less payer mix from the Medicare and Medicaid mix, the Medicare being higher reimbursement for skilled. And if their skilled patients are not going to that facility any longer for various reasons, and all they're getting are the Medicaid payer mix, they're not able to generate sufficient revenue to cover costs. And some of the compensating ways they look at it is the inability to pay staffing and hire more staff, so you reduce staffing, and therefore you reduce the amount of patients that or residents that you can take in. And so that's part of the analysis, and that's the concern that when Rich and I looked at this, that you would lose that opportunity. It doesn't mean that it's a definitive, yes, we're going to approve it, or no, it's not, but it allows the analysis to occur, and it allows for consideration of a condition that would require a percentage of mixed payer in order to ensure appropriate revenue coming into both providers. It still is a needs. Is there a need for this service in the community? And it's the payer mix is part of that analysis of not just the need, but how does it impact the existing providers and the existing resources in the community.
Okay, that's new information for me because I thought I had been told differently prior. Thank you for clarifying.
Representative Arford. Yes, thank you. Thank you, Madam Chair, and thank you for being here with us. We've received significant testimony on both sides of the coin, and some of the testimony is from other states saying that the con process, they don't use it anymore. They have very high limits, and they found that the research that they did showed that the con process was actually detrimental to their healthcare market, increased prices, et cetera, et cetera. So honestly, I'm looking to you as my trusted expert. And what do you know about other states and their experience with con and their limits what's the evidence out there that's happening in places where they do have higher limits?
Representative, I can't answer that because I'm not the expert.
Oh.
Rich Lawrence does our CON process, but also we haven't done a deep dive. One of the concerns that I have when you look at studies is, are you really comparing apples to apples, and what is the CON process? It varies. I know there have been several studies on that, and you've referenced members of this committee have provided with those studies. But there's various types of CON programs throughout the states. And our concern, with the threshold as being increased as proposed is it reduces and limits the ability to consider a project.
Okay. And just one quick follow-up. The figures you gave us, the different projects that have come across recently, what was the geographic distribution of those? I think you had like 6 you had urgent care, you had, what's where are they located?
The urgent care facilities you'll find mostly in the more populated parts of the state. So Auburn, Brunswick, the greater Portland area, here in Augusta, the Bangor area. You don't find urgent care centers in the more rural parts of the state because there isn't sufficient revenue and patient population to justify the expense.
So pretty much all the new build is happening in sort of central, the I-95 corridor, pretty much going down all the way down to New Hampshire.
You'll find all of these projects that I outlined, you will find them in the more populated parts of our state. So that in the more urban settings, you will not find them in the Jackman,
right,
Hancock County area. The more rural parts of our state, no, because there's not the payer mix and the patient population to support the expenses of operating such a facility.
Thank you very much.
Okay, further questions?
That's a question. That's my bill.
And you can ask clarifying questions. Sure.
Thank you, Madam Chair. So currently, a new ambulatory surgical center, you could build one for $2.9 million under current law. And then a year later, I can go out and I can spend 14 million and expand an existing healthcare facility without a review. Is that correct? I mean, that's what I'm reading here.
I would have to defer to Mr. Lawrence, but yes, because the needs analysis has already been determined for the need for that service.
But if, I mean, again, if you do a new healthcare facility, an ambulatory surgical center, and you say under the current 3 million, so you don't have to do a review. Let's say you build a 2 surgical unit. But then the next year you can come in under capital expenditures. So a new and existing hospitals, other existing healthcare facilities, excluding nursing homes. Right now, the threshold is 14 million without certificate of need. So you could build 2.9 million and then a year later build a 12 billion.
I honestly, Representative Foley, and I apologize, I don't know the intricacies of that threshold and that process. That's something I would have to defer to Mr. Lawrence, but I can share with you, and it is the example that I gave you of the existing ambulatory surgical center that increased from 2 beds to 4 and relocated, their cost that was subject to CON review was 1.9 million. And that was for the renovation of the floor that they were going to occupy for their new ambulatory surgical center facility with all of the equipment. Some of their equipment they would have brought from their existing facility to the new, but obviously they would have bought new equipment for the 2 additional surgical suites that they were installing there.
Further questions, Representative Flynn?
Thank you, Madam Chair. Maybe I missed it. Just a quick question. You said that you're comfortable at 5 million. Why not 7.5?
I corrected and said, well, I'm not comfortable. We were neither for nor against, because we see if the original 3 million had been subject to the CPI index, like all of the other programs, it would have been at 5 million. So that's why we feel that's an appropriate step, and then to have an incremental increase going forward. The concern with 7.5 and 10, with what we're seeing in some of the trends with how they're leasing and financing, means that there's going to be greater risk of more projects that would have been subject to at least an oversight review that would come in under that may impact.
Further questions, Representative Matthews?
Thank you. Thank you. I was just curious, does the department, since we haven't done a change in con law in what, 30 years, is it? This hasn't been raised? Is that, I guess that's my first question. Have we not raised this limit for about 30 years? Is that correct?
No,
Yeah.
2012.
Oh, we did. Okay,
Yeah.
thank you. Is there a time period where you review this to see whether or not you should make slow changes in this?
The amended bill that's come before, it's set at 5 million, really brings everything in line with annual CPI indexes. So it raises the 3 million to 5. So it essentially has everything at a 5 million, including nursing homes, which are currently at a 5 million, and then the annual CPI index going forward. This was the one provider type, and I was not here when that bill was passed in 2012, so I can't tell you what the argument or the rationale for increasing the hospitals and others and not these projects.
Thank you.
Okay, further questions? Seeing none, thank you very much.
Thank you.
Further discussion? So do we have a motion? Representative Olson.
The motion I would make would be to raise the level to 7.5 with CPI added each year after that,
Okay,
and ought to pass.
seconded by Representative Chimino. Further discussion? Okay, seeing none. Guess we're ready, Edna.
Thank you. Senator Bailey?
No.
Senator Bailey, no. Representative Matheson?
No.
Representative Matheson, no. Representative Arfoot?
No.
Representative Arfoot, no. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Shimino?
Yes.
Representative Shimino, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
No.
Representative Mastracchio, no. Representative Morris?
Yes,
Representative Morris, no. Representative Olson?
I was a yes.
Oh, I'm sorry, Representative.
I know, you're used to
Morris-
hearing no. but-
I know, you
It's a rare day.
You just had to do that to me. Okay, Representative Morris is a yes. Representative Olson?
Yes.
Representative Olson, yes. 6 members of the committee haven't voted in the affirmative and 4 in the negative.
And for me, I don't know about everyone
Yeah.
else, but it's the
The
5 million in
five,
the
keep it
CPI,
the original
amendment.
amendment. Okay, so 2 ought to pass as amended. All right.
No, 2 different reports of ought to pass as amended is what she meant.
Yeah, did I miss that? I
No,
thought there were just
no.
2. Okay, all right.
She thought you're talking about the number of people. that
Oh,
voted.
perfect. Okay.
Yeah.
Yeah,
Not the number of reports.
gotcha.
All right, so that'll close the work session on LD 1890. And we will open the work session on LD 2011, an act to remove the main care program from the prescription drug benefit provisions in the main insurance code.
So what first session? It's in 2011.
This is the first work session on this, yes. Yeah, I think that's it for the carryover bills. These are
Yeah.
New bills.
These are the bills.
So Edna's bringing this analysis around. I think this, as Representative Matheson asked, this is the first time you've had a work session on this one. We're moving out of carryover bill territory into new bill territory. This was a bill that was submitted by the Department of Health and Human Services to the committee. Under current law, for the purposes of Title 24A, Chapter 56C, which is the chapter in the insurance code that governs prescription drug benefits and regulates pharmacy benefits managers. The definition of a carrier for the purposes of the chapter includes the main care program, excuse me, and the state employee group health plan. This bill amends the definition of carrier to remove the main care program from the definition. That would make the main care program subject to certain, well, to all of the provisions in that chapter, although there are at least one provision where the committee has accepted or exempted the application of the provision to main care, and that was the legislation that the committee enacted last session with regard to spread pricing. But chapter 56C, and I included a copy of the whole chapter here for you when it was enacted by the 129th legislature, and it took effect in January 1 of 2020. The definition of carrier has included the main care program since it was enacted. It was something that was included in the original bill and remained unchanged by the committee amendment. If you move forward with the proposal, it has no fiscal impact. I don't know if anybody was here at that time. Representative Morris probably, and maybe, were you here? Do you remember this, Bill? Okay. I was just gonna say, my recollection, when I went back and looked as to why the definition of carrier included main care and the state employee health plan was at the time the legislation proposed to impose certain requirements on carriers and the PBMs that they contract with. And the interest was, as I remember, and I don't know, others can contradict me, was having, if the main care program was going to contract with a PBM, they would follow the same standards in terms of a PBM that would, they would have certain fiduciary duties that they would have to, you know, abide by. And there was a sense that if you were going to impose these requirements on carriers, you should treat everybody equally and include the state employee health plan to the extent that they would contract with the PBM. And the main care program. Arguably, there are specific provisions within the chapter, as the Department of Health and Human Services testimony has indicated, that don't necessarily fit for the main care program. So that's the policy decision for the committee to make. And there are specific provisions in Title 22 that govern the Department of Health and Human Services that have been put forward that sort of regulate and oversee the prescription drug benefits that would be provided through the main care program. So it's that's the question that the committee has to grapple with. So just in terms of the legislative history, I would offer that to you. I I would note that you didn't receive any testimony in opposition to this proposal, though, as far as I know. You did not at the public hearing, and I don't think you have received any written testimony since.
So can you give me an example of a PBM regulation that now applies to a main care PBM that would be lost by this change?
I mean, the question, I guess, is the testimony from the Department of Health and Human Services. I don't know if they've been complying, with these provisions, and I don't know if they've been enforced against them, but, for instance, there are provisions in this, 4349, where it talks about carrier is responsible for monitoring all activities carried out by the carrier or all activities carried out on behalf of the carrier by a PBM if they contract with, and that they have a fiduciary duty, to ensure that the carrier is, responsible for the PBM's management of the activities related to those prescription drug benefits. And there are specific contract requirements in section 4349. There were, network requirements, things like that, that I think, the question I think for you, and I think there are other provisions that would address some of these things.
Right,
So,
that was gonna be like my next question was, do we know if there are other regulations just under main care or, either the state program, the federal program that kind of addresses these things that would supersede them anyways?
I think there are things that would address them in part. I think the testimony, as I understood it from the department, was the confusion that comes up when there's legislation that's an act that's proposing to make changes to Chapter 56C, and they're asked, does this have any financial impact, or does this apply to the program? And I don't want to speak for the department. I don't know if the department is here. It can offer more rationale for the testimony, but it seemed to indicate to me most of it was a confusion about a provision of the insurance code that applies to a program that should be regulated by Title 22. That's where I think the disconnect is and where the suggestion is being made. But I'm just trying to point out to you the history of it.
Yeah.
And if you take it away, they wouldn't be subject to these provisions anymore.
Okay, thank you. Welcome.
I am Kristen Merrill, and representing the department. I'm the current acting associate policy director for Main Care. To address some of what was addressed there, our current contract with our vendor, Change Healthcare, we don't consider them to be a pharmacy benefits manager. We consider them in accordance with the definition in statute as referenced. They function more as a pharmacy benefits administrator. So it doesn't quite align with the previously mentioned legislation requirements and statutes. So thus far, every time a bill comes up, that's why we are commonly questioning whether or not it applies to us as a department, and the purpose behind the provisions in the legislation that changes to statute.
Yeah.
Yes, I don't understand. I'm sorry.
I'm even more confused.
Yeah, I think you confused me more. So are you saying that you don't ever use a PBM, so therefore this wouldn't apply, even though it does apply?
Our current vendor
Your
does not.
current vendor?
Yep, our current vendor does not align with the definition of a pharmacy benefits manager. They are more situated as a pharmacy benefits administrator.
Right, but have you worked with a PBM previously, or will you in the future?
That is a great question that I do not have an answer to. As far as our current contract, I don't believe there are any changes slated in the near future. But as we did mention in our testimony, I think the requirements in other areas of the statute, if warranted, could apply to Main Care through future changes in the event that we do contract with a benefits manager.
How is that? I guess I don't understand that.
Yeah, if there is changes necessary for any sections of statute where it would be applicable to the Main Care program, it could be amended to specifically include Main Care.
I need help. Representative Olson.
The problem I'm having here is this is certainly looks like a duck and walks like a duck and sounds like a duck. We are, Main Care is operating essentially as a carrier. They're doing exactly the same things as far as benefits and everything else as is Anthems, as is Harvard Pilgrim, as is Community Health Options and and others. And we're putting needed requirements on them. Main Care should be playing by the same set of rules. And so to exempt them from that, if they're saying that they're not dealing with a PBM right now, but when their next contract negotiation comes around and they do, maybe they'll go with a PBM, in which case then we've got to shut the door's been shut after the horse has already gone out. So, I mean, if we leave it as it is, then they're bound by that. If we take it out, then we're always going to be playing catch up.
So is there anything in regulations, either again at the state or federal level, that regulate PBMs when it comes to Main Care?
I'd have to look into the specific requirements referenced in the other sections of statute to see if there are federal regulations that correlate with them, but we can definitely take that back.
Okay. Further questions? That would make me feel better if I knew there was something else in place. Representative Arford.
Thank you, Madam Chair, and thank you for being here. This is definitely not my area of expertise. And I do have one question though, as it relates to commercial insurance and the Main Care. One is a for-profit entity, one is a not-for-profit entity. So does that play out here at all? Does that have any agency in terms of how we address this particular piece of legislation?
I think that's a great question. I think that's really dependent on the legislation at any given point in time that proposes whether or not it includes the program. As mentioned, there were, bills passed that I think it was probably more applicable to for-profit and not the Main Care program, which is commonly why we're seeking that clarification. I think unknowing, any future legislation, it's hard to say.
Yeah, and I do want to qualify. I understand the carrier is potentially a for-profit entity because not all are. But this is certainly it falls in that category. So that's why I was curious. Thank you.
Representative Foley.
Thank you, Madam Chair. I'm just curious, when I read the definition of pharmacy benefit manager in the statute, I don't understand why your person or entity you deal with doesn't fit that definition. Because so the pharmacy benefit manager means a person, business, or other entity that pursuant to a contract or under an employment relationship with a carrier, a self-insurance plan, or a third-party payer, either directly or through an intermediary, manages the prescription drug coverage provided by the carrier, a self-insurance plan, or other third-party payer, including but not limited to processing and paying claims for prescription drugs, performing drug utilization reviews, processing drug prior authorization requests, adjudicating appeals and grievances related to prescription drug coverage, or contracting with network pharmacies and controlling the cost of covered prescription drugs. So your person your entity that you deal with doesn't do those things?
It doesn't check all of the boxes. I'm happy to take that back and clarify the distinction in the definition.
Okay, thank you.
Senator Mastracchio.
Thank you, Madam Chair. I just want to say that Senator Foley was also here. I just looked the bill up and you were on, it was a 12-1 report. They were both ought to pass as amended. He was a different ought to pass as amended all by himself. So I'm not even sure. I think I know, but it's just interesting to me that it was, I'm looking through the paperwork and stuff and remembering the headache that it gave me then, because it's the same kind of headache that I'm getting now.
It's a complicated one.
It was very complicated, and that piece was the piece that was put in. I mean, I see it even in another amendment that went in there. So it's just wondering why at this point? I mean, obviously it's created some issues with people with it not applying, but people thinking it does.
That's correct. Yes.
Further questions? Representative Mastracchio.
So if we were to do nothing or kill the bill, what happens?
It's a great question. What's going to happen from a main care perspective is each time a bill comes up that could potentially apply, obviously we'll have to confer with the committee to ensure whether or not it's applicable to our program, and then address as such.
Can you quantify that for me? Like, how many times have you had to do this? Has it been a real, that to me is more important than, I mean, I just want to know how much time is it actually taking?
Sure. Well, so we have a representative within our office. Also, there's a representative within the commissioner's office at DHHS that monitor bills across the board. And so anytime a bill that would come through that would apply to this, it would be additional man hours by each of those individuals to track it, to confer with you all internally, monitor sessions. As far as hours, it would really depend on how many bills come through each session that could be applicable there. But thus far, I think in my office alone, we've spent probably, I'm going to estimate maybe a half a dozen hours on the last bill that came through in the last session, which was LD 1580. And that didn't include attending the sessions. The work sessions, the hearing.
And that was the bill on spread pricing that I mentioned.
Oh, that we were exempt from.
Yeah.
Okay, further questions? Great. Discussion, motion. Do you need more information? Do you need some Tylenol? Representative Foley.
Yeah, I believe the department's gonna come back with understanding what the definition of a PBM, why it doesn't fit into their contract. So I would want to know that, because I think that's what she's saying is that their person doesn't fit under that definition. I sort of want to know why.
Okay, thank you. Yeah, and I think I definitely want to know, again, we take this away, what's in place as far as federal rules, regulations, laws, whatever. Any other information people would like to have, as it looks like we're thinking about tabling. Ask now if we ever hold your peace, Representative. Okay. Okay, so Representative Mastracchio made a motion to table, Representative Foley seconded it. All those in favor? Great, so that motion passes. That'll be tabled. Thank you. And we'll open the work session on an act to amend the laws governing licensure of wholesalers and manufacturers under the Maine Pharmacy Act. Again, this is our first work session on this bill. 2019. Yes. Yep.
I'm trying to get out of here before 5 if I can.
Oh, yeah.
So LD
Muck
2019
things up on our last
is
bill.
coming around. This is also a department bill. This one was presented by the Office of Professional and Occupational Regulation within DPFR, the Board of Pharmacy. As it's drafted, it would modify the initial licensure qualifications for prescription drug manufacturers and wholesalers by allowing an applicant to apply for licensure before the applicant has obtained a registration number from the appropriate federal agencies, but requires that once licensed, the entity file the applicable registration numbers with the Board of Pharmacy once they're obtained by the manufacturer or the wholesaler. The bill also provides that the board may deny a license, refuse to renew a license, or impose disciplinary action if the manufacturer or wholesaler fails to file the applicable registration numbers with the board once the registration numbers are obtained. This was the bill that, as it was described by Ms. Valencourt, was sort of the chicken or the egg. You know, they weren't eligible to receive a license until they had the DEA number, but they weren't able to get the DEA number until they were licensed. So this proposal would allow the entity to receive the license by the Board of Pharmacy, and then once they receive the DEA number, then file that information with the Board of Pharmacy. It is drafted as an emergency. It includes an emergency preamble and an emergency clause so that the change can take effect immediately. And so just, you know, you all know an emergency needs a 2/3 vote. So there's no fiscal impact to the bill if it moves forward. And you do have the current laws attached for you.
Questions for Colleen? Representative Boyer.
Thank you, Madam Chair. So Colleen, what were they doing before? Like, or what are they doing now if we don't make this change or before this bill came up?
I mean, I think technically there was a difficulty in sort of in issuing the license until they had that information. And so they were in a conundrum, as I understand it, as to how to do it. So, and this change would just clarify the statute. So there's no questions moving forward about how it would operate. I mean,
Further questions? You can make a motion.
Thank you, Madam Chair. I will move up to pass on LD 2019.
Seconded by Representative Matheson. Further discussion? I think we're ready, Edna.
Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Rapport.
Yes.
Representative Rapport, yes. Senator Baldacci.
Yes.
You want to turn your mic on?
Yes.
Senator Baldacci, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Shamino.
Yes.
Representative Shamino, yes. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Olson.
Yes.
Representative Olson, yes. 10 members of the committee have been voted in the affirmative and 0 in the negative.
All right, thank you, Edna. That will close the work session on LD 2019. Open the work session on
30.
LD 2030. An act to expand the scope of practice of independent practice dental hygienists.
Yeah. So Edna has the bill analysis is coming around for this. You also have a chart, which is something that's printed off of what's called the Oral Healthcare Workforce Research Center. It's kind of difficult to read since it was printed off of their website, but it's an infographic that compares information in other states in terms of the scope of practice of dental hygienists. I think there were some questions at the public hearing about that. But if you look particularly at the sort of teal colored blue on the wheel, you'll see that's the scope of practice requirements in states that have to do with particularly the local anesthesia. And that's one of the elements of LD 2030. But this is a bill sponsored by Representative Mastracchio, and as drafted, it would allow independent practice dental hygienists to administer local anesthesia or nitrous oxide analgesia as long as the independent practice hygienist has the appropriate licensure authority. Under current law, which I attached for you starting on page 3 of the analysis, you'll see the scope of practice of an independent practice dental hygienist is expressly provided in current law. And I think everybody is aware that typically the statute does describe the scope of practice that's allowed for licensed professionals. And that's sort of always traditionally been kind of the purview of the legislature to expressly lay out the scope of practice for a licensee. So you'll see what the current provisions are with regard to independent practice dental hygienists. You'll also see, starting on page 4 and 5, the scope of practice for dental hygienists, and we'll get to how that relates. But under current law, a licensed dental hygienist must successfully complete a course of study and verify passage of all examinations required by board rule in order to be granted the authority to administer local anesthesia or nitrous oxide analgesia. So there is an ability, if you have a license as a dental hygienist, to undergo the appropriate training and be obtain the license authority to administer local anesthesia and nitrous oxide. There are specific requirements within the scope of practice for a licensed dental hygienist that requires that the administration of nitrous oxide be done under the direct supervision of a dentist. And with regard to local anesthesia, that's done under the general supervision of a dentist. Once somebody is licensed as a dental hygienist, they can obtain that additional licensing authority to obtain, to administer these medications. And then they further can get additional license authority to become an independent practice dental hygienist. So underlying the IPDH, I guess, is the acronym that they use. Their license is a license as a dental hygienist and the ability to obtain the licensing according to the board requirements to have the authority to administer these agents. Also wanted to point out for you, under current law, there are specific provisions both in the Title 24A, the insurance code, and MaineCare that require insurers that provide coverage for dental services, either through a dental health insurance plan or a general health plan. They are required to cover services performed by independent practice dental hygienists when those services are covered services under the contract and when they are within the lawful scope of practice. And MaineCare has a similar requirement to require that services provided by independent dental hygienists are required to be reimbursed under the MaineCare program if they are covered services. So as I mentioned, the bill would make it clear that if you're an independent practice dental hygienist, you may administer local anesthesia or nitrous oxide without the supervision of a dentist, as long as they have demonstrated that they have the appropriate licensing authority. The testimony that you received from OPOR indicated that there are, of the 1,466 dental hygienists that are licensed, 286 of them have the authority to practice as an independent practice dental hygienist. And of those actively licensed, 286, 201 have obtained the authority to administer local anesthesia, and 78 have the authority to administer both. And as I mentioned, the bill would remove the requirement that a dentist provide supervision over an independent practice dental hygienist administering local anesthesia or nitrous oxide. And as I mentioned, current law would require general supervision for local anesthesia and direct supervision for the administration of nitrous oxide. And I included for you what direct supervision and general supervision mean as defined in the statute. The hope or the intent of the bill, as I understand it, because independent practice dental hygienists have the ability to operate independently within their own practice, that if they have the appropriate training in the administration of these agents, that they should be able to do that without the supervisory requirements. And there's no fiscal impact if the legislation moves forward. And I'm happy to answer any questions that you may have.
All right, questions? Representative Stracchio.
I just want to say that I wanted to just add that independent practice hygienists, you just can't come out of school and become one. You have to have a number of hours. And I think is it 2,000? 2,000 hours before you can even think about doing that. So they're already in a different place. I know that was a question that I kind of got and they've existed for a long time. And I just want to draw your attention to the fact that the Maine Dental Association was in favor of this. So they understand that once hygienists are with these authorities, I will tell you that even in a practice, I doubt very much that someone is standing over somebody watching them, given it once, if they're working for a dentist, because hygienists are doing this in dental practices now. Independent hygienists are not able to utilize this properly, and that's the real issue that I think has been pointed out. They're operating independently, but not able to do all the things that they can do that would make it possible for them to treat everybody that walks in the door.
Any other questions for Colleen or a discussion? And Representative Mastracchio, did you want to talk about maybe adding an emergency clause?
I did. I was thinking that we have independent practice hygienists right now who are able to see people, have openings within, they're not waiting, 3 months or 6 months to see people. They're able to get people in. And I would really appreciate putting an emergency on this. To be honest, this was an after deadline bill. I was just happy to be able to get it in here and didn't even think about the emergency, but I think that would be appropriate.
And I would just say, having chaired the commission, hearing about the shortage and lack of dental care across the state, I mean, this certainly would help, right? It's like every little bit can help getting dental care to folks. Representative Chimino.
I just have a question. Under what circumstances would a dental hygienist need to be able to administer nitrous oxide?
So people have some fear. Some of the things that they do, let's face it, I don't know if anybody's had like a deep scaling where they, where they really get in there.
Don't.
But
Don't.
it can be painful, and that's why, in order to do the job properly, when I first started out in hygiene school, that wasn't, if somebody did that, it would be the dentist who would come in, give a shot, and then maybe you would do, if you worked for a periodontist, that's the kind of thing. But it has progressed to the point where hygienists are able to do that, and they're able to, they're doing it in offices now, and they've been doing it in Maine we have a history of not having problems and not having issues around them doing it. So I think that this was a natural progression.
So it would just be anything having to do with cleanings. It's not like they're doing anything else beyond that.
Yeah, they're basically, but it's not a cleaning like maybe you think of a cleaning. It's the kind you want to
deep cleaning,
prevent
there you
having
go.
to have. So if you go early, you won't have to ever do that.
Yeah. And again, on the commission, we heard about that was sometimes the biggest struggle was, people who had been not seen a dentist for a long time, getting them back in the door. And of course, this is a way to maybe get them back in the door and then get them on that, 6-month cycle. But you have to get over that initial fear and that deep cleaning. And so sometimes administering these is a way to do that, to tell people, no, it'll be okay because, you'll be knocked out or you'll be numb or whatever it is. Yeah. Yes, you'll be oblivious but you'll be happy at the end. And then again, hopefully then they can start coming every 6 months. So. Oh.
I'll just be there Friday night.
Further discussion, questions, Representative Arford.
Thank you, Madam Chair. And this is a question I had previously, and it's not a question that's going to make or break this in any way because I support this, but I'm still curious as to what other states. I think it's I can't pronounce it, but the second type of where is it here? Yeah, the nitrous oxide analgesia. I had asked how many other states are allowing for this, and I'm just curious. I always like to ask this question.
Yeah, so you can see on the chart, and it's hard to explain, and everybody's different, but the chart indicates with regard to other states who has the authority to administer local anesthesia or dental hygienists and under what circumstances. So you can see it's a little hard to if you see the sort of blue colored, which is like the third outer ring around the wheel for other states, you'll see the scope of practice in those states that would include the administration of local anesthesia. And then the letters indicate the type of supervision, direct, indirect, and general. What's difficult, and this is dental hygienist, so what's difficult to determine is we're specifically talking about independent practice dental hygienists, and there haven't been a lot of states that have to date have actively licensed individuals doing independent practice dental hygiene in their states, and there are a few of them. Minnesota, Colorado, Vermont's just passed the legislation, and there are a number of other states that are enacting legislation, but it's difficult and hard to compare statutes, and scopes of practice vary. So I wasn't able to, in looking at those states, to find any specific mention of the nitrous oxide specifically. But in all those states, an independent practice dental hygienist has to be a dental hygienist first. And it goes back to the authority. And so you can see on this chart, the authority they have within their scope of practice to administer this pain medication, and under what circumstances, if they were a lower level dental hygienist, they were able to do it with some supervision. And some states vary. Some it's indirect supervision, some it's general, and some it's direct. And also the states statutes, unfortunately, also define what supervision means differently too, and the categories of that supervision differently. So it's hard to say, hard to answer your question specifically for the independent practice dental hygienist, but the color wheel sort of does give you the information about dental hygienists in other
Yeah,
states.
so one of the reasons I like this bill is because based on this information, then I think it's fair to say that passing this bill might act to further encourage people who want to serve as independently licensed folks and be able to offer the service would be attracted to coming here to Maine to do this work. And that would be a good thing. Representative, what's your name? Matheson. I wanted to say Mostracchio. I'm like, I know that's not Mostracchio.
I really appreciate the hard work that's gone into this and the incremental changes that have happened. And I love that all the stakeholders came together and that the dentists are supporting this. So I would like to make a motion not to pass as amended unless I'm overstepping. Okay, thank you.
And the amendment is to add the emergency
And
clause.
just the amendment is adding an emergency.
Yes, correct.
Okay.
I really want to thank everybody for understanding what we're doing, but really take a look at what we did and in that hearing, and it took years to get to this point of trust. And so I just ask you all to remember that, because it's worth it, even though I will tell you back in 2013, 14, there were a lot of tears around what I was involved with, and they had been involved with it for years before that. And I now appreciate, and someone told me, this is how it works. Just stop crying and vote for it. And they were right, because it takes time to develop the trust so that you can have this kind of change that I cannot believe. I'll be honest, if you had told me back then that this would be as painless as it was,
No pun intended.
I would have never believed it. Right.
Did
you like that?
That's right.
It's almost like we had local anesthesia. Okay, with that, Edna, I think we're ready.
Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Arford?
Yes.
Representative Arford, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Shamino?
Yes.
Representative Shamino, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 10 members of the committee having voted in the affirmative and 0 in the negative.
All right, thank you. And that will close the work session at LD 2030. I think that's all of our work.
Do we have, what is this?
Good job, everyone. Thank you so much.
So, well, I guess I'll say one thing. You have two bills, I think, that have not been voted on that were subject to the carryover deadline.
Right.
LD 1803,
Right.
which is the optometry bill.
Yeah.
Which you have given the parties some additional time to come back, I think, come back Tuesday, next week and update you and we'll see what happens. And then LD 1220, which is the bill having to do with animal chiropractic care. The
Ah.
interested parties meetings just started last week. There's another one scheduled on Friday. So those are the two that have not yet been voted. And so I anticipate asking permission of the presiding officers to have some additional time to continue working on those bills and explain that the interested parties are still doing their work. You also have 3 placeholder carryovers,
Right.
concept drafts.
Which
that-
those aren't subject.
That aren't subject to that deadline. So just to give you an update, but otherwise you didn't table anything else today. So you voted all the other carryovers,
All the carryovers,
right?
yes.
Yeah.
You did. Yeah, so
didn't-
there's only 2 we have to
Just
ask
two.
permission to go beyond the
So
deadline.
just to let everybody know, there are.
Great.
two.
Thank you.
Yeah, I just want to update you on the chiropractic bill. We had a very good meeting on Friday. Thank you, Ms. Valancourt, for her due diligence. We started out on opposite ends of the spectrum, but it's starting to come together. So I think maybe after the next meeting, I think we'll have some positive traction. So we
Great.
hope to maybe be able to be back to you in a couple of weeks. So, but it was positive.
Great. Thank you all for that. All right. Anything else, Colleen? All right. So we are adjourned.